Thymoma 632. The component Thymoma 632. The components of the hematopoietic system have been traditionally divided into the myeloid tissues, which include the bone marrow and the cells derived from it, and the lymphoid tissues, consisting of the thymus, lymph nodes, and spleen. It is important to recognize, however, that this subdivision is artificial with respect to both the normal physiology of hematopoietic cells and the diseases affecting them. For example, although bone marrow contains relatively few lymphocytes, it is the source of all lymphoid progenitors and the home of long-lived plasma cells and memory lymphocytes. Similarly, neoplastic disorders of myeloid progenitor cells originate in the bone marrow, but secondarily involve the spleen and the lymph nodes. Some red cell disorders result from the formation of autoantibodies, indicating a primary disorder of lymphocytes. Thus, it is not possible to draw neat lines between diseases involving the myeloid and lymphoid tissues. Recognizing this difficulty, we somewhat arbitrarily divide diseases of the hematopoietic tissues into two chapters. In this chapter, we discuss white cell diseases and disorders affecting the spleen and thymus. In Chapter 14, we consider diseases of red cells and those affecting hemostasis. Before delving into specific diseases, we will briefly discuss the origin of normal hematopoiesis. Blood cell progenitors. Blood cell progenitors first appear during the third week of embryonic development in the yolk sac. Cells derived from the yolk sac are the source of long-lived tissue macrophages, such as microglial cells in the brain and Kupffer cells in the liver, but the contribution of the yolk sac to blood formation, mainly in the form of embryonic red cells, is only transient. Definitive hematopoietic stem cells arise several weeks later in the mesoderm of the intraembryonic aortogonad mesonephros region. During the third month of embryogenesis, HSCS migrate to the liver, which becomes the chief site of blood cell formation until shortly before birth. HSCS also take up residence in the fetal placenta. This pool of HSCS is of uncertain physiologic relevance but has substantial clinical importance, as HSCS harvested at birth from umbilical cord blood are used in therapeutic HSC transplantation. By the fourth month of development, HSCS shift in location yet again to the bone marrow. By birth, marrow throughout the skeleton is hematopoietically active, and hepatic hematopoiesis dwindles to a trickle, persisting only in scattered foci that become inactive soon after birth. After puberty, hematopoiesis ceases in distal bones and becomes restricted to the axial skeleton. Thus, in normal adults, only about half of the marrow space is hematopoietically active. The formed elements of blood, red cells, granulocytes, monocytes, platelets, and lymphocytes have a common origin from HSCS, pluripotent cells that sit at the apex of a hierarchy of bone marrow progenitors. Most evidence supporting this scheme comes from studies in mice, but human hematopoiesis is believed to proceed in a similar way. The development of mature blood cells from HSCS involves progressive commitment to increasingly specialized cell populations. HSCS give rise to several kinds of early progenitor cells that have more restricted differentiation potential, such that they ultimately produce mainly myeloid cells or lymphoid cells. The origins of lymphoid cells are revisited when tumors derived from these cells are discussed. These early progenitors in turn give birth to progenitors that are further constrained in their differentiation potential. Some of these cells are referred to as colony-forming units because they produce colonies composed of specific kinds of mature cells when grown in culture. From the various committed progenitors are derived the morphologically recognizable precursors, such as myeloblasts, proerythroblasts, and megakaryoplasts, which are the immediate progenitors of mature granulocytes, red cells, and platelets. HSCs have two essential properties that are required for the maintenance of hematopoiesis: pluripotency and the capacity for self-renewal. Pluripotency refers to the ability of a single HSC to generate all mature blood cells. When an HSC divides, at least one daughter cell must self-renew to avoid stem cell depletion. Self-renewing divisions occur within a specialized marrow niche, in which stromal cells and secreted factors nurture and protect the HSCs. As one might surmise from their ability to migrate during embryonic development, HSCs are not sessile, particularly under conditions of stress, such as severe anemia or acute inflammation. HSCs are mobilized from the bone marrow and appear in the peripheral blood. In fact, HSCs used in transplantation are now mainly collected from the peripheral blood of donors treated with granulocyte colony stimulating factor, one of the factors that can mobilize marrow HSCs from their stem cell niches. The marrow response to short-term physiologic needs is regulated by hematopoietic growth factors through their effects on the committed progenitors. These growth factors are called colony-stimulating factors because they were discovered by their ability to support the growth of colonies of blood cells in vitro. Because mature blood elements are terminally differentiated cells with finite lifespans, their numbers must be constantly replenished. In current models of hematopoiesis, some divisions of HSCs give rise to cells referred to as multipotent progenitors, which are more proliferative than HSCs, but have a lesser capacity for self-renewal. Division of multipotent progenitors gives rise to at least one daughter cell that leaves the stem cell pool and begins to differentiate. Once past this threshold, these newly committed cells lose the capacity for self-renewal and commence an inexorable journey down a road that leads to terminal differentiation and death. However, as these progenitors differentiate, they also proliferate rapidly in response to growth factors, expanding their numbers. Some growth factors, such as stem cell factor and FLT3 ligand, act through receptors that are expressed on very early committed progenitors. Others, such as erythropoietin, granulocyte macrophage cholinostimulating factor, GCSF, and thrombopoietin, act through receptors that are expressed only on committed progenitors with more restricted differentiation potentials. Feedback loops involving these lineage-specific growth factors tune the marrow output, allowing the numbers of formed blood elements to be maintained within appropriate ranges. Many diseases alter the production of blood cells. The marrow is the ultimate source of most cells of the innate and adaptive immune system and responds to infectious or inflammatory challenges by increasing its output of granulocytes under the direction of specific growth factors. Table 13.1 Adult Reference Ranges for Blood Chelsea Cell Type Range: White cells 4.8, 10.8, granulocytes 40-17, neutrophils 1.4, 6.5, lymphocytes 1.2, 3, 4, monocytes 0.1, 0.6, eosinophils 0, 0.5, basophils 0, 0.2, red cells men 4.35, women 3.55, platelets 150, 450. Our reference ranges vary among laboratories. The reference ranges for the laboratory providing the result should always be used. Stem cells, committed precursors, late precursors, and mature forms. Pronk cell, Prank cell, NK cell, hematopoietic stem cell, multipotent progenitor, early progenitor with lymphoid potential, prob cell, prot cell, lymphopoiesis, preb cell, pret cell, CFUG, myeloblast neutrophil, B-cell T-cell, CFU mix, CFU-M, CFU-EO, self-renewal, monoblast eosinophilo, basophilo, megakaryote, erythroblast, blast, oblast, monocyte, eosinophil, basophil, platelets, erythrocyte, early progenitor with myeloid potential, CFU-B-ME, CFU-B, CFU-MG, CFU-E, cell division, CIT SCA1 LIN, lineage-specific markers, lineage-specific growth factor receptors. Figure 13.1 differentiation of blood cells. CFU, colony-forming unit, LIN, negative for lineage-specific markers, NK, natural killer, and cytokines. By By contrast, many other disorders are associated with defects in hematopoiesis that lead to deficiencies of one or more types of blood cells. Primary tumors of hematopoietic cells are among the most important diseases that interfere with marrow function, but certain genetic diseases, infections, toxins, and nutritional deficiencies, as well as chronic inflammation from any cause, may also decrease the production of blood cells by the marrow. Tumors of hematopoietic origin are often associated with mutations that block progenitor cell maturation or abrogate their growth factor dependence. The net effect of such derangements is an unregulated clonal expansion of hematopoietic elements, which replace normal marrow progenitors and often spread to other hematopoietic tissues. In some instances, these tumors originate from transformed HSCs that retain the ability to differentiate along multiple lineages, whereas in other instances, the origin is a more differentiated progenitor that has acquired an abnormal capacity for self-renewal. Morphology. The bone marrow is a unique microenvironment that supports the orderly proliferation, differentiation, and release of blood cells. It is filled with a network of thin-walled sinusoids lined by a single layer of endothelial cells, which are underlaid by a discontinuous basement membrane and adventitial cells. Within the interstitium lie clusters of hematopoietic cells and fat cells. Differentiated blood cells enter the circulation by transcellular migration through the endothelial cells. The normal marrow is organized in subtle but important ways. For example, normal megakaryocytes lie next to sinusoids and extend cytoplasmic processes that bud off into the bloodstream to produce platelets. While red cell precursors often surround macrophages that dispose of nuclear remnants produced when red cells disgorge their nucleus prior to release into the bloodstream, processes that distort the marrow architecture, such as deposits of metastatic cancer or granulomatous disorders, can cause the abnormal release of immature precursors into the peripheral blood, a finding that is referred to as leukoerythroblastosis. Marrow aspirate smears provide the best assessment of the morphology of hematopoietic cells. The most mature marrow precursors can be identified based on their morphology alone. Immature precursors of different types are morphologically similar and must be identified definitively using lineage-specific antibodies and histochemical markers. Bone marrow biopsies are a good means for estimating marrow activity. In normal adults, the ratio of fat cells to hematopoietic elements is about 1:1. In hypoplastic states, the proportion of fat cells is greatly increased. Conversely, fat cells often disappear when the marrow is involved by hematopoietic tumors, and in diseases characterized by compensatory hyperplasias and neoplastic proliferations such as leukemias. Other disorders induce local marrow fibrosis. In such cases, the marrow usually cannot be aspirated, and the lesions are best seen in biopsies. Disorders of white cells. Disorders of white blood cells can be classified into two broad categories: proliferative disorders, in which there is an expansion of leukocytes, and leukopenias, which are defined as a deficiency of leukocytes. Proliferations of white cells can be reactive or neoplastic. Reactive proliferations in the setting of infections or inflammatory processes, when large numbers of leukocytes are needed for an effective host response, are fairly common. Neoplastic disorders, though less frequent, are much more important clinically. In the following discussion, we will first describe the leukopenic states and summarize the common reactive disorders, and then consider in some detail the malignant proliferations of white cells. Leukopenia. The number of circulating white cells may be decreased in a variety of disorders. An abnormally low white cell count usually results from reduced numbers of neutrophils. Lymphopenia is less common. In addition to congenital immunodeficiency diseases, it is most commonly observed in advanced human immunodeficiency virus infection following therapy with glucocorticoids or cytotoxic drugs. Autoimmune disorders, malnutrition, and certain acute viral infections. In the latter setting, Lymphopenia actually stems from lymphocyte redistribution, rather than a decrease in the number of lymphocytes in the body. Acute viral infections induce production of type 1 interferons, which activate T lymphocytes and change the expression of surface proteins that regulate T-cell migration. These changes result in the sequestration of activated T cells in lymph nodes and increased adherence to endothelial cells, both of which contribute to lymphopenia. Granulocytopenia is more common and is often associated with diminished granulocyte function, and thus merits further discussion. Neutropenia, agranulocytosis. Neutropenia, a reduction in the number of neutrophils in the blood, occurs in a wide variety of circumstances. Agranulocytosis, a marked reduction in neutrophils, has the serious consequence of making individuals susceptible to bacterial and fungal infections. Pathogenesis. Neutropenia can be caused by inadequate or ineffective granulopoiesis or increased destruction or sequestration of neutrophils in the periphery. Inadequate or ineffective granulopoiesis is observed in the setting of suppression of HSCS, as occurs in aplastic anemia and a variety of infiltrative marrow disorders. In these conditions, granulocytopenia is accompanied by anemia and thrombocytopenia. Suppression of committed granulocytic precursors by exposure to certain drugs. Disease states associated with ineffective hematopoiesis, such as megaloblastic anemia and myelodysplastic syndrome, in which defective precursors die in the marrow. Rare congenital conditions in which inherited defects in specific genes impair granulocytic differentiation. Accelerated destruction or sequestration of neutrophils occurs with immunologically mediated injury to neutrophils, which can be idiopathic, associated with a well-defined immunologic disorder or caused by exposure to drugs. Splenomegaly, in which splenic enlargement leads to sequestration and destruction of neutrophils in the spleen, and modest neutropenia, sometimes associated with anemia and often with thrombocytopenia. Increased peripheral utilization, which can occur in overwhelming bacterial, fungal, or rickettsial infections. The most common cause of agranulocytosis is drug toxicity. Certain drugs, such as alkylating agents and antimetabolites used in cancer treatment, produce agranulocytosis in a predictable, dose-related fashion. Because such drugs cause a generalized suppression of hematopoiesis, production of red cells and platelets is also affected. Agranulocytosis may also occur as an idiosyncratic reaction to a large variety of agents, including certain antibiotics, anticonvulsants, anti-inflammatory drugs, antipsychotic drugs, and diuretics. The neutropenia induced by antipsychotic agents such as chlorpromazine and related phenothiazines results from a toxic effect on granulocytic precursors in the bone marrow. In contrast, agranulocytosis, following administration of other drugs, such as sulfonamides, probably stems from antibody-mediated destruction of neutrophils through mechanisms similar to those involved in drug-induced immunohemolytic anemias. In some patients with acquired idiopathic neutropenia, autoantibodies directed against neutrophil-specific antigens are detected. Severe neutropenia may also occur in association with monoclonal proliferations of large granular lymphocytes. The mechanism of this neutropenia is not clear. Suppression of granulocytic progenitors by products of the neoplastic cell is considered most likely. Morphology. The alterations in the bone marrow vary with cause. With excessive destruction of neutrophils in the periphery, the marrow is usually hypercellular due to a compensatory increase in granulocytic precursors. Hypercellularity is also the rule with neutropenias caused by ineffective granulopoiesis, as occurs in megaloblastic anemia and myelodysplastic syndrome. Agranulocytosis caused by agents that suppress or destroy granulocyte precursors is understandably associated with marrow hypocellularity. Infections are a common consequence of agranulocytosis. Ulcerating, necrotizing lesions of the gingiva, floor of the mouth, buccal mucosa, pharynx, or elsewhere in the oral cavity are quite characteristic. These are typically deep, undermined, and covered by gray to green-black necrotic membranes from which numerous bacteria or fungi can be isolated. Less frequently, similar ulcerative lesions occur in the skin, vagina, anus, or gastrointestinal tract. Severe, life-threatening invasive bacterial or fungal infections may occur in the lungs, urinary tract, and kidneys. The neutropenic patient is at particularly high risk for deep fungal infections caused by Candida and Aspergillus. Sites of infection often show a massive growth of organisms with little leukocytic response. In the most dramatic instances, bacteria grow in colonies resembling those seen on agar plates. Reactive proliferations of white cells and lymph nodes. Leukocytosis. Leukocytosis refers to an increase in the number of white cells in the blood. It is a common reaction to a variety of inflammatory states. Pathogenesis. The peripheral blood leukocyte count is influenced by several factors including the size of the myeloid and lymphoid precursor and storage cell pools in the bone marrow, thymus, circulation, and peripheral tissues. The rate of release of cells from the storage pools into the circulation, the proportion of cells that are adherent to blood vessel walls at any time, the rate of extravasation of cells from the blood into tissues. As discussed in Chapter 3, leukocyte homeostasis is maintained by cytokines, growth factors, and adhesion molecules through their effects on the proliferation, differentiation, and extravasation of leukocytes and their progenitors. Table 13.2 summarizes the major mechanisms of neutrophilic leukocytosis and its causes, the most important of which is infection. In acute infection, there is a rapid increase in the egress of mature granulocytes from the bone marrow pool, an alteration that may be mediated through the effects of tumor necrosis factor and interleukin-1. If the infection or an inflammatory process is prolonged, IL-1, TNF, and other inflammatory mediators stimulate macrophages, bone marrow stromal cells, and T cells to produce increased amounts of hematopoietic growth factors. These factors enhance the proliferation and differentiation of committed granulocytic progenitors, and over several days cause a sustained increase in neutrophil production. Some growth factors preferentially stimulate the production of a single type of leukocyte. For example, IL-5 mainly stimulates eosinophil production while G-CSF induces. Table 13.2 Mechanisms and causes of leukocytosis: increased marrow production, chronic infection or inflammation, paraneoplastic myeloproliferative neoplasms, e.g. chronic myeloid leukemia, growth factor independent, increased release from marrow stores, acute inflammation, chronic inflammation, decreased margination, exercise catecholamines, decreased extravasation into tissues, glucocorticoids. Clinical features: the symptoms and signs of neutropenia are related to infection and include malaise, chills, and fever, often followed by marked weakness and fatigability. With the granulocytosis, infections are often overwhelming and may cause death within hours to days. Serious infections are most likely when the neutrophil count falls below 500. Because infections are often fulminant, broad-spectrum antibiotics must be given expeditiously whenever signs or symptoms appear. In some instances, such as following myelosuppressive chemotherapy, neutropenia is treated with G-CSF, a growth factor that stimulates the production of granulocytes from marrow precursors. Table 13.3 Causes of leukocytosis. Type of leukocytosis: neutrophilic leukocytosis, eosinophilic leukocytosis, basophilic leukocytosis, monocytosis, lymphocytosis. Causes: acute bacterial infections, especially those caused by pyogenic organisms, sterile inflammation caused by, for example, tissue necrosis. Allergic disorders such as asthma, hay fever, parasitic infestations, drug reactions, certain malignancies e.g. Hodgkin and some non-Hodgkin lymphomas, autoimmune disorders e.g. pemphigus, dermatitis, herpetiformis, and some vasculitides, atherosclerotic disease, rare, often indicative of a myeloproliferative neoplasm. Chronic infections, bacterial endocarditis, rickettsiosis and malaria, autoimmune disorders, inflammatory bowel diseases. Accompanies monocytosis in many disorders associated with chronic immunologic stimulation, e.g. tuberculosis, brucellosis, viral infections, bordetella, pertussis infection, neutrophilia. Such factors are differentially produced in response to various pathogenic stimuli, and, as a result, the 5 principal types of leukocytosis tend to be observed in different clinical settings. In sepsis or severe inflammatory disorders, leukocytosis is often accompanied by morphologic changes in neutrophils, such as toxic granulations, dull bodies, and cytoplasmic vacuoles. Toxic granules, which are coarser and darker than normal neutrophilic granules, represent abnormal azurophilic granules. Dull bodies are patches of dilated endoplasmic reticulum that appear as sky blue cytoplasmic puddles. In most instances, it is not difficult to distinguish reactive and neoplastic leukocytoses, but uncertainties may arise in 2 settings. Acute viral infections, particularly in children, can cause the appearance of large numbers of activated lymphocytes that resemble neoplastic lymphoid cells. At other times, particularly in severe infections, many immature granulocytes appear in the blood, mimicking a myeloid leukemia. Special laboratory studies are helpful in distinguishing reactive and neoplastic leukocytoses. Figure 13.2 Reactive changes in neutrophils. Neutrophils containing coarse purple cytoplasmic granules and blue cytoplasmic patches of dilated endoplasmic reticulum are observed in this peripheral blood smear prepared from a patient with bacterial sepsis. Lymphadenitis following their initial development from precursors in the central lymphoid organs, the bone marrow for B cells, and the thymus for T cells. Lymphocytes circulate through the blood and under the influence of specific cytokines and chemokines, home to lymph nodes, spleen, tonsils, adenoids, and Peyer's patches, which constitute the peripheral lymphoid tissues. Lymph nodes, the most widely distributed and easily accessible lymphoid tissue, are frequently examined for diagnostic purposes. They are discrete encapsulated structures that contain separate B-cell and T-cell zones, each richly invested with phagocytes and antigen-presenting cells. The activation of resident immune cells leads to morphologic changes in lymph nodes. Within several days of antigenic stimulation, the primary follicles enlarge and develop pale staining germinal centers, highly dynamic structures in which B cells acquire the capacity to make high-affinity antibodies against specific antigens. Paracortical T-cell zones may also undergo hyperplasia. The degree and pattern of morphologic change are dependent on the inciting stimulus and the intensity of the response. Trivial injuries and infections induce subtle changes, while more significant infections inevitably produce nodal enlargement and sometimes leave residual scarring. For this reason, lymph nodes in adults are almost never normal or resting, and it is often necessary to distinguish morphologic changes secondary to past experience from those related to present disease. Infections and inflammatory stimuli often elicit regional or systemic immune reactions within lymph nodes. Some that produce distinctive morphologic patterns are described in other chapters. Most, however, cause stereotypical patterns of lymph node reaction designated acute and chronic non-specific lymphadenitis. Acute non-specific lymphadenitis. Acute lymphadenitis in the cervical region is most often due to drainage of microbes or microbial products from infections of the teeth or tonsils. While in the axillary or inguinal regions, it is most often caused by infections in the extremities. Acute lymphadenitis also occurs in mesenteric lymph nodes in the setting of acute appendicitis and other inflammatory conditions involving the gut, a differential diagnosis that plagues the surgeon. Systemic viral infections, particularly in children and bacteremia, often produce acute generalized lymphadenopathy. Morphology. The nodes are swollen, gray-red, and engorged. Microscopically, there is prominence of large reactive germinal centers containing numerous mitotic figures. Macrophages often contain particulate debris derived from dead bacteria or necrotic cells. When pyogenic organisms are the cause, neutrophils are prominent, and the centers of the follicles may undergo necrosis. Sometimes the entire node is converted to pus. With less severe reactions, scattered neutrophils infiltrate about the follicles and accumulate within the lymphoid sinuses. The endothelial cells lining the sinuses become activated and enlarge in size. Nodes involved by acute lymphadenitis are swollen and painful. When abscess formation is extensive, the nodes become fluctuant. The overlying skin is red. Sometimes suppurative infections penetrate through the capsule of the node and track to the skin to produce draining sinuses. Healing of such lesions is associated with scarring. Chronic nonspecific lymphadenitis. A wide variety of chronic immunologic stimuli may produce nonspecific lymphadenitis. Several different patterns of morphologic change are seen, often within the same lymph node. Morphology. Follicular hyperplasia is caused by stimuli that activate humoral immune responses. It is defined by the presence of large oblong germinal centers, which are surrounded by a collar of small resting naive B cells. Germinal centers are polarized, consisting of two distinct regions, a dark zone with proliferating blast-like B cells and a light zone composed of B cells with irregular or cleaved nuclear contours. Interspersed among the germinal center B cells is an inconspicuous network of antigen-presenting follicular dendritic cells and macrophages containing the nuclear debris of B cells, which undergo apoptosis if they fail to produce an antibody with a high affinity for antigen. Causes of follicular hyperplasia include rheumatoid arthritis, toxoplasmosis, and early HIV infection. This form of hyperplasia is morphologically similar to follicular lymphoma. Features favoring a reactive hyperplasia include preservation of the lymph node architecture, including the interfollicular T-cell zones and the sinusoids, marked variation in the shape and size of the follicles, and the presence of frequent mitotic figures, phagocytic macrophages, and recognizable light and dark zones, all of which tend to be absent from neoplastic follicles. Paracortical hyperplasia is caused by stimuli that trigger T-cell mediated immune responses, such as acute viral infections. The T-cell regions typically contain immunoblasts, activated T-cells 3 to 4 times the size of resting lymphocytes that have round nuclei, open chromatin, several prominent nucleoli, and moderate amounts of pale cytoplasm. Figure 13.3 Follicular hyperplasia. Low power view showing a reactive follicle and surrounding mantle zone. The dark staining mantle zone is more prominent adjacent to the germinal center light zone in the left half of the follicle. The right half of the follicle consists of the dark zone. High power view of the dark zone shows several mitotic figures and numerous macrophages containing phagocytosed apoptotic cells. The expanded T-cell zones encroach on and in particularly exuberant reactions may efface the B-cell follicles. In such cases, immunoblasts are so numerous that special studies may be needed to exclude a lymphoid neoplasm. In addition, there is often hypertrophy of sinusoidal and vascular endothelial cells, sometimes accompanied by infiltrating macrophages and eosinophils. Sinus histiocytosis is marked by an increase in the number and size of the endothelial cells that line lymphatic sinusoids, and increased numbers of intrasinusoidal macrophages, which expand and distort the sinusoids. This form of hyperplasia may be particularly prominent in lymph nodes draining cancers such as carcinoma of the breast. Characteristically, lymph nodes in chronic reactions are non-tender, as enlargement occurs slowly over time and acute inflammation with associated tissue damage is absent. Chronic lymphadenitis is particularly common in inguinal and axillary nodes, which drain relatively large areas of the body and are frequently stimulated by immune reactions to trivial injuries and infections of the extremities. Chronic immune reactions also can promote the appearance of organized collections of immune cells in non-lymphoid tissues. These collections are sometimes called tertiary lymphoid organs. A classic example is that of chronic gastritis caused by Helicobacter pylori, in which aggregates of mucosal lymphocytes are seen that simulate the appearance of Peyer's patches. A similar phenomenon occurs in rheumatoid arthritis, in which B-cell follicles often appear in the inflamed synovium. Lymphotoxin, a cytokine required for the formation of normal Peyer's patches, is probably involved in the establishment of these extranodal inflammation-induced collections of lymphoid cells. Hemophagocytic lymphohistiocytosis. Hemophagocytic lymphohistiocytosis is a reactive condition marked by cytopenias and signs and symptoms of systemic inflammation related to macrophage activation. For this reason, it is also sometimes referred to as macrophage activation syndrome. Some forms are familial and may appear early in life, even in infants, while other forms are sporadic and may affect people of any age. Pathogenesis. The common feature of all forms of HLH is systemic activation of macrophages and CD8 cytotoxic T cells. The activated macrophages phagocytose blood cell progenitors in the marrow and formed elements in the peripheral tissues, while the stew of mediators released from macrophages and lymphocytes suppress hematopoiesis and produce symptoms of systemic inflammation. These effects lead to cytopenias and a shock-like picture, sometimes referred to as cytokine storm or the systemic inflammatory response syndrome. Familial forms of HLH are associated with several different mutations, all of which impact the ability of cytotoxic T cells and natural killer cells to properly form or deploy cytotoxic granules. How these defects lead to HLH is not known. One common trigger for HLH is Epstein-Barr virus infection, suggesting that in some instances HLH stems from a defect in the ability of CD8 CTLs to kill infected cells. As a result of the persistent infection, the CTLs continue to make cytokines, leading to excessive macrophage activation. HLH is also a common complication of peripheral T-cell lymphoma, a tumor of mature T cells that is marked by immune dysregulation. Regardless of the trigger, HLH is uniformly associated with extremely high levels of inflammatory mediators such as interferon gamma, TNF-alpha, IL-6, and IL-12. Clinical features: most patients present with an acute febrile illness associated with splenomegaly and hepatomegaly. Hemophagocytosis is usually seen on bone marrow examination, but is neither sufficient nor required to make the diagnosis. Laboratory studies typically reveal anemia, thrombocytopenia, and very high levels of plasma ferritin and soluble IL-2 receptor, both indicative of severe inflammation, as well as elevated liver function tests and triglyceride levels, both related to hepatitis. Coagulation studies may show evidence of disseminated intravascular coagulation. If untreated, this picture can progress rapidly to multi-organ failure, shock, and death. Treatment involves the use of immunosuppressive drugs, mild chemotherapy, and administration of an antibody that neutralizes the activity of interferon gamma. Patients with germline mutations that cause HLH or who have persistent resistant disease are candidates for HSC transplantation. Without treatment, the prognosis is grim, particularly in those with familial forms of the disease, who typically survive for less than 2 months. With prompt treatment, with or without subsequent HSC transplantation, roughly half of patients survive, though many do so with significant sequelae, such as renal damage in adults and growth retardation and intellectual disability in children. Neoplastic proliferations of white cells overview. Malignancies are clinically the most important disorders of white cells. These diseases fall into 3 broad categories. Lymphoid neoplasms include a diverse group of tumors of B-cell, T-cell, and NK cell origin. In many instances, the phenotype of the neoplastic cell closely resembles that of a particular lymphocyte class or stage of maturation, a feature that is used in the diagnosis and classification of these disorders. Myeloid neoplasms arise from early hematopoietic progenitors. Three categories of myeloid neoplasia are recognized. Acute myeloid leukemias, in which immature progenitor cells accumulate in the bone marrow, myelodysplastic syndromes, which are associated with ineffective hematopoiesis and resultant peripheral blood cytopenias, and myeloproliferative neoplasms, in which increased production of one or more terminally differentiated myeloid elements usually leads to elevated peripheral blood counts. The histiocytoses are uncommon proliferative lesions of macrophages and dendritic cells. Although histiocyte is an archaic morphologic term, it is still often used. A special type of immature dendritic cell, the Langerhans cell, gives rise to a spectrum of neoplastic disorders referred to as the Langerhans cell histiocytoses. Etiologic and pathogenetic factors in white cell neoplasia. As in other cancers, the development of white blood cell neoplasms involves genetic alterations, infections, and sometimes a background of chronic inflammation. Different types of tumors show different abnormalities and are therefore responsive to different therapies. Before delving into this complexity, we consider themes of general relevance to their etiology and pathogenesis. Chromosomal translocations and other acquired mutations. Non-random chromosomal abnormalities, most commonly translocations, are present in the majority of white cell neoplasms. Many of these alterations are specifically associated with particular neoplasms and have a critical role in their genesis. Recurrently affected genes are often those that play crucial roles in the development, growth, or survival of the normal. Increased self-renewal, mutations in transcription, factors that influence self-renewal, pro-growth mutations, tyrosine kinase mutations, MyC translocation, increased cell division Warburg metabolism, decreased apoptosis, pro-survival mutations, figure 13.4 pathogenesis of white cell malignancies. Various tumors harbor mutations that principally affect maturation or enhance self-renewal, drive growth, or prevent apoptosis. Examples of each type of mutation are listed. Details are provided later under specific tumor types. Counterpart of the malignant cell. Mutations in certain genes are so strongly associated with specific tumor types that in some instances they are required for particular diagnoses. Some of these mutations produce a dominant negative protein that interferes with the normal function. In others, the result is an inappropriate increase in some normal activity. Oncoproteins created by genomic aberrations often block normal maturation, turn on pro-growth signaling pathways, or protect cells from apoptotic cell death. Figure 13. 4 highlights several well-characterized driver mutations and their pathogenic consequences in particular white cell neoplasms. Many oncoproteins cause an arrest in differentiation, often at a stage when cells are proliferating rapidly. The importance of this mechanism is most evident in the acute leukemias, in which dominant negative oncogenic mutations involving transcription factors interfere with early stages of lymphoid or myeloid cell differentiation. Other mutations in transcriptional regulators directly enhance the self-renewal of tumor cells, giving them stem cell-like properties. These types of mutations often collaborate with mutations that constitutively activate tyrosine kinases, which in turn activate RAS and its 2 downstream signaling arms, the PI3K, AKT, and MAPK pathways, thereby driving cell growth. Finally, mutations that inhibit apoptosis are prevalent in certain hematologic malignancies. Proto-oncogenes are often activated in lymphoid cells by errors that occur during attempted antigen receptor gene diversification. Among lymphoid cells, potentially oncogenic mutations occur most frequently in germinal center B cells. After antigen stimulation, B cells enter germinal centers and upregulate the expression of activation-induced cytosine deaminase, a specialized DNA-modifying enzyme that is essential for 2 types of immunoglobulin gene modifications: class switching, an intragenic recombination event in which the IgM heavy chain constant gene segment is replaced with a different constant segment, leading to a switch in the class of antibody produced, and somatic hypermutation, which creates point mutations within Ig genes that may increase antibody affinity for antigen. Certain proto-oncogenes, such as MyC, are activated in germinal center B-cell lymphomas by translocations to the transcriptionally active Ig locus. Remarkably, AID expression induces MyC translocations in a small fraction of normal germinal center B cells, apparently because AID creates lesions in DNA that lead to chromosomal breaks. Mistargeting of AID also is implicated in point mutations that upregulate the expression and activity of BCL6, an oncogenic transcription factor with an important role in several B-cell malignancies. Another type of regulated genomic instability that is unique to precursor B and T cells is attributable to VJ recombinase, which cuts DNA at specific sites within the Ig and T cell receptor loci respectively. This process is essential for generating diversity in assembled antigen receptor genes, but sometimes goes awry, leading to the joining of proto-oncogenes to antigen receptor gene regulatory elements. The resulting overexpression of the involved proto-oncogene converts it to an oncogene. This mechanism is particularly prevalent in tumors of precursor T cells, but is observed in other types of lymphoid neoplasms as well. Inherited genetic factors. As discussed in Chapter 7, individuals with genetic diseases that promote genomic instability, such as Bloom syndrome, Fanconi anemia, and ataxia telangiectasia, are at increased risk of acute leukemia. In addition, both Down syndrome and type 1 neurofibromatosis are associated with an increased incidence of childhood leukemia. Viruses. 3 lymphotropic viruses, human T-cell leukemia virus 1, EBV, and human herpes virus 8, have been implicated as causative agents in particular lymphomas. The possible mechanisms of transformation by viruses are discussed in Chapter 7. HTLV1 is associated with adult T-cell leukemia lymphoma. EBV is found in a subset of Burkitt lymphoma, 30% to 40% of Hodgkin lymphoma, many B-cell lymphomas arising in the setting of T-cell immunodeficiency, and rare NK cell lymphomas. In addition to Kaposi sarcoma, HHV8 is associated with an unusual B-cell lymphoma that presents as a malignant effusion, often in the pleural cavity. Chronic inflammation. Several agents that cause localized chronic inflammation predispose to lymphoid neoplasia, which almost always arises within the inflamed tissue. Examples include the associations between H. pylori infection and gastric B-cell lymphomas, gluten-sensitive enteropathy and intestinal T-cell lymphomas, and even breast implants, which are associated with an unusual subtype of T-cell lymphoma. This can be contrasted with HIV infection, which is associated with an increased risk of B-cell lymphomas that may arise within virtually any organ. Early in the course, T-cell dysregulation by HIV infection causes a systemic hyperplasia of germinal center B cells that is associated with an increased incidence of germinal center B-cell lymphomas. In advanced infection, severe T-cell immunodeficiency further elevates the risk for B-cell lymphomas, particularly those associated with EBV and KSHV, HHV8. These relationships are discussed in more detail in Chapter 6. Iatrogenic factors. Ironically, radiation therapy and certain forms of chemotherapy used to treat cancer increase the risk of subsequent myeloid and lymphoid neoplasms. This association stems from the mutagenic effects of ionizing radiation and chemotherapeutic drugs on hematolymphoid progenitor cells. Smoking. The incidence of AML is increased 1.3 to 2-fold in smokers, presumably because of exposure to carcinogens such as benzene in tobacco smoke. Lymphoid neoplasms. Taken together, the diverse lymphoid neoplasms constitute a complex, clinically important group of cancers, with about 100,000 new cases being diagnosed each year in the United States. Definitions and classifications. Neoplasms that present with widespread involvement of the bone marrow and the peripheral blood are called leukemias. Proliferations of white cells, typically lymphocytes that usually present as discrete tissue masses, are called lymphomas. Originally, these terms were attached to what were considered distinct entities, but with time and increased understanding, these divisions have blurred. Many entities called lymphoma occasionally have leukemic presentations, and evolution to leukemia is not unusual during the progression of incurable lymphomas. Conversely, tumors identical to leukemia sometimes arise as soft tissue masses without detectable bone marrow disease. Hence, the terms leukemia and lymphoma merely reflect the usual tissue distribution of each disease at presentation. Within the large group of lymphomas, Hodgkin lymphoma is segregated from other forms, which constitute the non-Hodgkin lymphomas. Hodgkin lymphoma has distinctive pathologic features and is treated in a unique fashion. Another special group of tumors includes plasma cell neoplasms. These most often arise in the bone marrow and only infrequently involve lymph nodes or the peripheral blood. The clinical presentation of lymphoid neoplasms is most often determined by the anatomic distribution of disease. 2/3 of NHLs and virtually all Hodgkin lymphomas present as enlarged non-tender lymph nodes. The remaining NHL is present with symptoms related to the involvement of extranodal sites. Lymphocytic leukemias most often come to attention because of signs and symptoms related to the suppression of normal hematopoiesis by tumor cells in the bone marrow, whereas the most common plasma cell neoplasm, multiple myeloma, causes bony destruction of the skeleton and often presents with pain due to pathologic fractures. Other symptoms are frequently caused by proteins secreted from tumor cells or from immune cells responding to the tumor. Specific examples include the plasma cell tumors, in which much of the pathophysiology is related to the secretion of whole antibodies or Ig fragments. Hodgkin lymphoma, which is often associated with fever related to the release of cytokines from non-neoplastic inflammatory cells. And peripheral T-cell lymphomas, tumors of functional T cells that often release pro-inflammatory cytokines and chemokines. Historically, few areas of pathology evoked as much controversy as the classification of lymphoid neoplasms, but consensus has been reached through use of objective molecular diagnostic tools. The current World Health Organization classification scheme uses morphologic, immunophenotypic, genotypic, and clinical features to sort the lymphoid neoplasms into 5 broad categories. Separated according to the cell of origin: 1. Precursor B-cell neoplasms, neoplasms of immature B cells. 2. Peripheral B-cell neoplasms. 3. Precursor T-cell neoplasms, neoplasms of immature T cells. Table 13.4 World Health Organization classification of lymphoid neoplasms. First, precursor B-cell neoplasms. B-cell acute lymphoblastic leukemia lymphoma. Second, peripheral B-cell neoplasms. Chronic lymphocytic leukemia, small lymphocytic lymphoma, B-cell prolymphocytic leukemia, lymphoplasmacytic lymphoma, splenic and nodal marginal zone lymphomas, extranodal marginal zone lymphoma, mantle cell lymphoma, follicular lymphoma, marginal zone lymphoma, hairy cell leukemia, plasmacytoma, plasma cell myeloma, diffuse large B-cell lymphoma, Burkitt lymphoma. Third, precursor T-cell neoplasms, T-cell acute lymphoblastic leukemia lymphoma. Fourth, peripheral T-cell and NK cell neoplasms. T-cell prolymphocytic leukemia, large granular lymphocytic leukemia, mycosis fungoides, Sézary syndrome, peripheral T-cell lymphoma. Unspecified anaplastic large cell lymphoma, angioimmunoblastic T-cell lymphoma, enteropathy-associated T-cell lymphoma, panniculitis-like T-cell lymphoma, hepatosplenic, gamma-delta T-cell lymphoma, adult T-cell leukemia lymphoma, extranodal NK T-cell lymphoma, NK cell leukemia. Fifth, Hodgkin lymphoma, classic subtypes, nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte depletion, nodular lymphocyte predominant, NK natural killer, Peripheral T-cell and NK cell neoplasms of mature T-cells and NK cells. 5. Hodgkin lymphomas, neoplasms of Reed-Sternberg cells, and variants. Before discussing the specific entities, some important principles relevant to lymphoid neoplasms should be emphasized. Lymphoid neoplasia can be suspected based on clinical features, but histologic examination of lymph nodes or other involved tissues is required for diagnosis. Analysis of lineage-specific protein expression and genetic alterations is an important complement to the morphologic studies. Markers recognized by antibodies that are helpful in the characterization of lymphomas and leukemias are listed in Table 13.5. Antigen receptor gene rearrangement generally precedes transformation of lymphoid cells, hence all daughter cells derived from the malignant progenitor share the same antigen receptor gene configuration and sequence and synthesize identical antigen receptor proteins. In contrast, normal immune responses are comprised of polyclonal populations of lymphocytes that express many different antigen receptors. Thus, analyses of antigen receptor genes and their protein products can be used to distinguish reactive and malignant lymphoid proliferations. In addition, each antigen receptor gene rearrangement produces a unique DNA sequence that constitutes a highly specific clonal marker, which can be used to detect small numbers of residual malignant lymphoid cells after therapy. Most lymphoid neoplasms resemble some recognizable stage of B or T cell differentiation, a feature that is used in their classification. The vast majority of lymphoid neoplasms are of B cell origin, with most of the remainder being T cell tumors. Tumors of NK cell origin are rare. Lymphoid neoplasms are often associated with immune abnormalities, both a loss of protective immunity and a breakdown of tolerance may be seen, sometimes in the same patient. In a further ironic twist, individuals with inherited or acquired immunodeficiency are themselves at high risk of developing certain lymphoid neoplasms, particularly those caused by oncogenic viruses. Neoplastic B and T cells tend to recapitulate the behavior of their normal counterparts like normal lymphocytes. Neoplastic B and T cells express adhesion molecules and chemokine receptors that govern their homing to certain tissue sites, leading to characteristic patterns of involvement. For example, follicular lymphomas home to germinal centers in lymph nodes, whereas cutaneous T-cell lymphomas home to the skin. Variable numbers of neoplastic B and T lymphoid cells also recirculate through the lymphatics and peripheral blood to distant sites. As a result, most lymphoid tumors are widely disseminated at the time of diagnosis. Notable exceptions to this rule include Hodgkin lymphomas, which are sometimes restricted to one group of lymph nodes, and marginal zone B-cell lymphomas, which are often restricted to sites of chronic inflammation. Table 13.5. Some immune cell antigens detected by monoclonal antibodies. Antigen designation, normal cellular distribution, primarily T-cell associated. CD1 thymocytes and Langerhans cells. CD3 thymocytes, mature T cells. CD4 helper T cells, subset of thymocytes. CD5 T cells, and small subset of B cells. CD8 cytotoxic T cells, subset of thymocytes, and some NK cells, primarily B cell associated. CD10 pre-B cells and germinal center B cells. CD19 pre-B cells and mature B cells, but not plasma cells. CD20 pre-B cells after CD19 and mature B cells, but not plasma cells. CD21 EBV receptor, mature B cells and follicular dendritic cells. CD23 activated mature B cells. CD79A marrow pre-B cells and mature B cells, primarily monocyte or macrophage associated. CD11C granulocytes, monocytes, and macrophages, also expressed by hairy cell leukemias. CD13 immature and mature monocytes and granulocytes, CD14 monocytes, CD15 granulocytes, Reed-Sternberg cells and variants, CD33 myeloid progenitors and monocytes, CD64 mature myeloid cells, primarily NK cell associated, CD16 NK cells and granulocytes, CD56 NK cells and a subset of T cells, primarily stem cell and progenitor cell associated, CD34 pluripotent hematopoietic stem cells and progenitor cells of many lineages. Activation markers, CD30 activated B cells, T cells, and monocytes. Reed-Sternberg cells and variants, present on all leukocytes. CD45 or leukocytes, also known as leukocyte. Common antigen, CD, cluster designation, EBV, Epstein-Barr virus, NK, natural killer. Hodgkin lymphoma spreads in an orderly stepwise fashion, whereas most forms of NHL disseminate widely and somewhat unpredictably early in their course. Hence, while lymphoma staging provides useful prognostic information, it is of most utility in guiding therapy in Hodgkin lymphoma. We begin our discussion of specific entities with neoplasms of immature lymphoid cells and then move to mature B-cell tumors, plasma cell neoplasms, and tumors of T cells and NK cells. Some of the salient molecular and clinical features of these neoplasms are summarized in Table 13.6. We will finish by discussing Hodgkin lymphoma, B-cell neoplasms, T-cell neoplasms, bone marrow thymus, precursor B lymphoblastic lymphoma leukemias, small lymphocytic lymphoma, chronic lymphocytic leukemia, CLP, BLB, NBC, CD4, DN, DP, CD8, precursor T lymphoblastic, lymphoma, leukemias, multiple myeloma, mantle cell lymphoma MC, follicular lymphoma, Burkitt lymphoma, diffuse large B-cell, lymphoma, Hodgkin lymphoma, GC, PTC, peripheral, T-cell lymphomas, diffuse large B-cell lymphoma, marginal zone, lymphoma, small lymphocytic lymphoma, chronic lymphocytic leukemia. Figure 13.5, origin of lymphoid neoplasms. Stages of B and T cell differentiation from which specific lymphoid tumors emerge are shown. BLB, pre-B lymphoblast. CLP, common lymphoid precursor. DN, CD4, CD8, double negative pro-T cell. DP, CD4, CD8, double positive pre-T cell. GC, germinal center B cell. MC, mantle B cell. MZ, marginal zone B cell. NBC, naive B cell. PTC, peripheral T cell. Precursor B and T-cell neoplasms, acute lymphoblastic leukemia, lymphoma. Acute lymphoblastic leukemia, lymphomas are neoplasms composed of immature B or T cells, which are referred to as lymphoblasts. About 85% are B-alls, which typically manifest as childhood acute leukemias. The less common T-alls tend to present in adolescent males as thymic lymphomas. There is, however, considerable overlap in the clinical behavior of B-all and T-all. For example, B-all uncommonly presents as a mass in the skin or a bone, and many T-alls present with or evolve to a leukemic picture. Because of their morphologic and clinical similarities, the various forms of all are discussed here together. All is the most common cancer of children. Approximately 2,500 new cases are diagnosed each year in the United States, most occurring in individuals younger than 15 years of age. All is almost 3 times more common in Caucasians than in African Americans and is slightly more frequent in boys than in girls. Hispanics have the highest incidence of any ethnic group. B all peaks in incidence at about the age of 3, perhaps because the number of normal bone marrow pre-B cells is greatest very early in life. Similarly, the peak incidence of T-all is in adolescence, the age when the thymus reaches maximum size. B-all and T-all also occur less frequently in adults of all ages. Pathogenesis. Many of the chromosomal aberrations seen in all dysregulate the expression and function of transcription factors required for normal B and T cell development. Most TALs have mutations in Notch1, a gene that is essential for T cell development, while a high fraction of BALs have mutations affecting genes such as PAX5, TCF3, ETV6, and RUNX1, all of which are required for the proper differentiation of early hematopoietic precursors. By disturbing the expression and function of master regulatory factors, these mutations promote maturation arrest and increase self-renewal, a stem cell-like phenotype. Similar themes are relevant in the genesis of AML. In keeping with the multi-step origin of cancer, mutations in transcription factor genes are not sufficient to produce all. The identity of other driver mutations is Table 13.6, Summary of Major Types of Lymphoid Leukemias and Non-Hodgkin Lymphomas. Diagnosis cell of origin genotype salient clinical features. Neoplasms of immature B and T cells. B-cell acute lymphoblastic bone marrow diverse chromosomal translocations, predominantly children. Symptoms relating to leukemia, lymphoma precursor B-cell T involving RUNX1 and ETV6 marrow replacement and pancytopenia. Present in 25% aggressive. T-cell acute lymphoblastic precursor T-cell. Often diverse chromosomal translocations, predominantly adolescent males. Thymic masses and leukemia lymphoma of thymic origin, Notch1 mutations, variable bone marrow involvement, aggressive, neoplasms of mature B cells, Burkitt lymphoma, germinal center B cell translocations involving MyC and IG adolescents or young adults with extranodal. Low T, usually T subset masses, uncommonly presents as leukemia, EBV-associated aggressive, diffuse large B-cell germinal center, or diverse chromosomal rearrangements, all ages, but most common in older adults, often lymphomab post, germinal most often of BCL6. BCL2 appears as a rapidly growing mass, 30% center B-cell, or MyC extranodal aggressive. Extranodal marginal zone memory. B-cell T and T creating. Arises at extranodal sites in adults with chronic lymphoma MALT1 IAP2, BCL10 IGH, and inflammatory diseases may remain localized. MALT1 IGH fusion genes, respectively indolent. Follicular lymphomab germinal center B-cell T, creating BCL2 IGH fusion gene older adults with generalized lymphadenopathy and marrow involvement. Indolent. Hairy cell leukemia memory B-cell activating BRAF mutations older men with pancytopenia and splenomegaly. Indolent. Mantle cell lymphoma naive B-cell T creating cyclin D1-ish fusion older men with disseminated disease moderately. Gene aggressive, multiple myeloma solitary post-germinal center, diverse rearrangements involving IgG myeloma, older adults with lytic bone lesions, plasmacytoma bone marrow 13q, deletions pathologic fractures, hypercalcemia, and renal homing plasma cell failure, moderately aggressive. Plasmacytoma, isolated plasma cell masses in bone or soft tissue, indolent. Small lymphocytic naive B-cell or trisomy 12, deletions of 11q, 13q, and older adults with bone marrow lymph node. Lymphoma, chronic memory B-cell 17p, Notch1 mutations, splicing spleen and liver disease, autoimmune hemolysis, lymphocytic leukemia factor mutations, and thrombocytopenia in a minority, indolent. Neoplasms of mature T cells or NK cells. Adult T-cell leukemia, helper T-cell HTLV1 provirus, present in tumor cells, adults with cutaneous lesions, marrow involvement. Lymphoma and hypercalcemia occurs mainly in Japan, West Africa, and the Caribbean. Aggressive. Peripheral T-cell helper or cytotoxic T, no specific chromosomal abnormality, mainly older adults. Usually presents with lymphoma, unspecified cell lymphadenopathy, aggressive, anaplastic large cell cytotoxic T-cell rearrangements of ULK, anaplastic large children and young adults, usually with lymph node. Lymphoma cell lymphoma kinases in a subset and soft tissue disease. Aggressive. Extranodal NK T-cell or EBV associated. No specific adults with destructive extranodal masses. Most lymphoma cytotoxic T-cell chromosomal abnormality, commonly sinonasal aggressive. Mycosis fungoid Sézary helper T-cell. No specific chromosomal abnormality. Adult patients with cutaneous patches, plaques, syndrome, nodules, or generalized erythema, indolent. Large granular 2-type cytotoxic T-point mutations in STAT3 adult patients with splenomegaly, neutropenia, and lymphocytic leukemia cell and NK cell anemia, sometimes accompanied by autoimmune disease. A most common tumors in children. B most common tumors in adults. EBV, Epstein-Barr virus, HTLV1, human T-cell leukemia virus 1, IG, immunoglobulin, NK, natural killer. Incomplete, but aberrations that promote cell growth, such as mutations that increase tyrosine kinase activity and RAS signaling, are commonly present. Emerging data from deep sequencing of all genomes suggest that fewer than 10 mutations are sufficient to produce full-blown all, hence compared to solid tumors, all is genetically simple. Approximately 90% of alls have numerical or structural chromosomal changes. Most common is hyperploidy greater than 50 chromosomes, but hypoploidy and a variety of balanced chromosomal translocations also are seen. Changes in chromosome numbers are of uncertain pathogenic significance, but are important because they frequently correlate with immunophenotype and sometimes prognosis. For example, hyperdiploidy and hypodiploidy are seen only in B-all and are associated with better and worse prognoses respectively. In addition, B-all and T-all are associated with completely different sets of translocations. Thus, while morphologically identical, they are genetically quite distinct. Morphology. In leukemic presentations, the marrow is hypercellular and packed with lymphoblasts, which replace normal marrow. Elements. Mediastinal thymic masses occur in 50% to 70% of T-alls, which are also more likely than B-all to be associated with lymphadenopathy and splenomegaly. In both B-all and T-all, the tumor cells have scant basophilic cytoplasm and nuclei, somewhat larger than those of small lymphocytes. The nuclear chromatin is delicate and finely stippled, and nucleoli are usually small and often demarcated by a rim of condensed chromatin. The nuclear membrane is often deeply subdivided, imparting a convoluted appearance. In keeping with the aggressive clinical behavior, the mitotic rate is high, as with other rapidly growing lymphoid tumors, interspersed macrophages ingesting. Apoptotic tumor cells may impart a starry sky appearance. Because of their different responses to chemotherapy, all must be distinguished from AML, a neoplasm of immature myeloid cells that can cause identical signs and symptoms. Compared with myeloblasts, lymphoblasts have more condensed chromatin, less conspicuous nucleoli, and smaller amounts of cytoplasm that usually lacks granules. However, these morphologic distinctions are not absolute, and definitive diagnosis relies on stains performed with antibodies specific for B and T cell antigens. Histochemical stains are also helpful in that lymphoblasts are myeloperoxidase negative and often contain periodic acid Schiff, positive cytoplasmic material. Immunophenotype. Immunostaining for terminal deoxynucleotidal transferase, a specialized DNA polymerase that is expressed only in pre-B and pre-T lymphoblasts, is positive in more than 95% of cases. B-alls are arrested at various stages of pre-B cell development, which correlate with the expression of certain proteins. The lymphoblasts usually express the pan-B cell marker CD19 and the transcription factor PAX5, as well as CD10. In very immature B-alls, CD10 is negative, Alternatively, more mature, late pre-B-alls express CD10, CD19, CD20, and cytoplasmic IgM heavy chain. Similarly, T-alls are arrested at various stages of pre-cell development. In most cases, the cells are positive for CD1, CD2, CD5, and CD7. The more immature tumors are usually negative for surface CD3, CD4, and CD8, whereas late cell tumors are positive for these markers. Clinical features. Although ALLs and AMLs are genetically and immunophenotypically distinct, they are clinically very similar. In both, the accumulation of neoplastic blasts in the bone marrow suppresses normal hematopoiesis by physical crowding, competition for growth factors, and other poorly understood mechanisms. The common features, and those more characteristic of all, are the following. Abrupt stormy onset within days to a few weeks of the first symptoms. B. ACD22. Figure 13.6. Acute lymphoblastic leukemia lymphoma. Lymphoblasts with condensed nuclear chromatin, small nucleoli, and scant granular cytoplasm. Phenotype of all shown in analyzed by flow cytometry. The lymphoblasts represented by the red dots express terminal deoxynucleotidyl transferase and the B-cell marker CD22. The same cells are positive for two other markers, CD10 and CD19, commonly expressed on pre-B lymphoblasts. Thus, this is a B-all. Symptoms related to depression of marrow function, including fatigue due to anemia, fever, reflecting infections secondary to neutropenia, and bleeding due to thrombocytopenia. Mass effects caused by neoplastic infiltration, including bone pain resulting from marrow expansion and infiltration of the subperiosteum, generalized lymphadenopathy, splenomegaly, and hepatomegaly, testicular enlargement, and in T-all, complications related to compression of large vessels and airways in the mediastinum. Central nervous system manifestations such as headache, vomiting, and nerve palsies resulting from meningeal spread, all of which are also more common in all. Treatment of pediatric ALL is one of the great success stories of oncology. With aggressive chemotherapy, about 95% of children with ALL obtain a complete remission, and 75% to 85% are cured. Despite these achievements, however, ALL remains a leading cause of cancer deaths in children, and only 35% to 40% of adults are cured. Several factors are associated with a worse prognosis. Age younger than 2 years. Largely because of the strong association of infantile, all with translocations involving the MLL gene, presentation in adolescence or adulthood. And peripheral. Intracellular TDT CD19. C. Blood blast counts greater than 100,000, which probably reflects a high tumor burden. Favorable prognostic markers include age between 2 and 10 years, a low white cell count, hyperdiploidy, trisomy of chromosomes 4, 7, and 10, and the presence of a T. Notably, the molecular detection of residual disease after therapy is predictive of a worse outcome in both B-all and TT-AL and is being used to guide clinical trials. Although most chromosomal aberrations in all alter the function of transcription factors, the T instead creates a fusion gene that encodes a constitutively active BCR ABL tyrosine kinases, described in more detail under chronic myeloid leukemia. In B-all, the BBCR ABL protein is usually 190 kDa in size and has stronger tyrosine kinase activity than the form of BBCR ABL that is found in chronic myeloid leukemia, in which a BCR ABL protein of 210 kDa in size is usually seen. Treatment of TT-positive ALLs with BBCR ABL kinase inhibitors in combination with conventional chemotherapy is highly effective and has greatly improved the outcome for this molecular subtype of B-all in children and adults. Of interest, cryptic rearrangements involving genes encoding tyrosine kinases other than ABL also have been described in B-all, particularly in adults, and these too may be therapeutic targets. The outlook for adults with ALL lacking targetable molecular lesions remains more guarded, in part because of differences in the molecular pathogenesis of adult and childhood ALL, and also because older adults cannot tolerate the intensive chemotherapy regimens that are curative in children. Dramatic responses in all have been achieved with chimeric antigen receptor T cells directed against the B cell antigen CD19, but at high cost and with associated toxicities that have sometimes proved fatal. Key concepts: acute lymphoblastic leukemia, lymphoblastic lymphoma. Most common type of cancer in children may be derived from either precursor B or T cells. Highly aggressive tumors manifest with signs and symptoms of bone marrow failure or as rapidly growing masses. Tumor cells contain genetic lesions that block differentiation, leading to the accumulation of immature non-functional blasts. A subset of tumors contains activating mutations in tyrosine kinases that are important targets of therapy. Peripheral B-cell neoplasms. Chronic lymphocytic leukemia, small. Lymphocytic lymphoma. Chronic lymphocytic leukemia and small lymphocytic lymphoma differ only in the degree of peripheral blood lymphocytosis. Most affected patients have sufficient lymphocytosis to fulfill the diagnostic requirement for CLL. CLL is the most common leukemia of adults in the Western world. There are about 15,000 new cases of CLL each year in the United States. The median age at diagnosis is 60 years and there is a 2-1 male predominance. In contrast, SLL constitutes only of NHLs. CLL. SLL is much less common in Japan and other Asian countries than in the West. Pathogenesis. Unlike most other lymphoid malignancies, chromosomal translocations are rare in CLL, SLL. The most common genetic anomalies are deletions of 13q, 11q, and 17p, and trisomy 12q. Molecular characterization of the region deleted on chromosome 13 has implicated 2 microRNAs, MIR15A and MIR16-1, tumor suppressor genes. Loss of these MIRs is believed to result in overexpression of the anti-apoptotic protein BCL2, which is uniformly observed in CLL-SLL. DNA sequencing has revealed that the Ig genes of some CLL, SLL are somatically hypermutated, whereas others are not, suggesting that the cell of origin may be either a post-germinal center memory B cell or a naive B cell. For unclear reasons, tumors with unmutated Ig segments pursue a more aggressive course. Deep sequencing of CLL genomes has also revealed gain-of-function mutations involving the Notch1 receptor in 10% to 18% of tumors, as well as frequent mutations in genes that regulate RNA splicing. The growth of CLL, SLL cells is largely confined to proliferation centers, where tumor cells receive critical cues from the microenvironment. Stroma. Cells in proliferation centers express a variety of factors that stimulate the activity of the transcription factors, nuclear factor kappa B, which promotes cell survival, and MyC, which promotes cell growth. Other critical signals are generated by the B-cell receptor, which triggers a signaling pathway that includes Bruton tyrosine kinase. The importance of BTK in B cells is emphasized by congenital X-linked agammaglobulinemia, a failure of BB cell development that is caused by loss of function mutations in the BTK gene. Notably, BTK inhibitors produce sustained therapeutic responses in a high fraction of CLL patients, indicating that CLL cells depend on B cell receptor signaling and BTK activity for their growth and survival. Morphology. Lymph nodes are diffusely effaced by predominantly small lymphocytes, 6 to 12 micrometers in diameter, with round to slightly irregular nuclei, condensed chromatin, and scant cytoplasm. Admixed are variable numbers of larger activated lymphocytes that often gather in loose aggregates referred to as proliferation centers that contain mitotically active cells. When present, proliferation centers are pathognomonic for CLL, SLL. The blood contains variable numbers of small round lymphocytes with scant cytoplasm. Some of these cells are usually disrupted in the process of making smears, producing so-called smudge cells. In almost all cases, the bone marrow, spleen, and liver also are involved, albeit to widely varying degrees. Immunophenotype. CLL, SLL has a distinctive immunophenotype. The tumor cells express the pan-B cell markers CCD19 and CCD20, as well as CCD23 and CCD5, the latter A. Marker that is found on a small subset of normal B cells. Low-level expression of surface Ig is also typical, as is high-level expression of BCL2. A. Figure 13.9. Small lymphocytic lymphoma, chronic lymphocytic leukemia involving the liver. Low-power view of a typical periportal lymphocytic infiltrate. B. Figure 13.7. Small lymphocytic lymphoma, chronic lymphocytic leukemia. Low power view shows diffuse effacement of nodal architecture. At high power, the majority of the tumor cells are small, round lymphocytes. A prolymphocyte, a larger cell with a centrally placed nucleolus, is also present in this field. Figure 13.8, chronic lymphocytic leukemia. This peripheral blood smear is flooded with small lymphocytes with condensed chromatin and scant cytoplasm. A characteristic finding is the presence of disrupted tumor cells, 2 of which are present in this smear. A coexistent autoimmune hemolytic anemia explains the presence of spherocytes. A nucleated erythroid cell is present in the lower left-hand corner of the field. In this setting, circulating nucleated red cells could stem from premature release of progenitors in the face of severe anemia. Marrow infiltration by tumor or both. Clinical features: patients are often asymptomatic at diagnosis. When symptoms appear, they are nonspecific and include easy fatigability, weight loss, and anorexia. Generalized lymphadenopathy and hepatosplenomegaly are present in 50% to 60% of symptomatic patients. The leukocyte count is highly variable. Leukopenia can be seen in individuals with SLL and marrow involvement, while counts in excess of 200,000 are sometimes seen in CLL patients with heavy tumor burdens. A small monoclonal Ig spike is present in the blood of some patients. At the other end of the spectrum are asymptomatic patients with monoclonal B cells in their peripheral blood that number too few to merit the diagnosis of CLL. This condition, referred to a monoclonal lymphocytosis of uncertain significance, is considered to be a precursor lesion and progresses to symptomatic CLL at a rate of 1% per year. CLL/SL disrupts normal immune function through uncertain mechanisms. Hypogammaglobulinemia is common and contributes to an increased susceptibility to infection, particularly those caused by bacteria. Conversely, 10% to 15% of patients develop hemolytic anemia or thrombocytopenia due to autoantibodies made by non-neoplastic B cells. The course and prognosis are extremely variable and depend primarily on the clinical stage. Overall median survival is 4 to 6 years, but is more than 10 years in individuals with minimal tumor burden at diagnosis. Other variables that correlate with a worse outcome include the presence of deletions of 11q and 17p, a lack of somatic hypermutation, the expression of ZAP70, a protein that augments signals produced by the Ig receptor, and the presence of Notch1 mutations. Symptomatic patients are generally treated with gentle chemotherapy and immunotherapy with antibodies against proteins found on the surface of CLL/SL cells, particularly CD20. Newly available, highly active targeted therapies include BTK inhibitors and BCL2 inhibitors. Their impact on the disease course is still being determined. Another factor that impacts patient survival is the tendency of CLL/SLL to transform to a more aggressive tumor. Most commonly, this takes the form of a transformation to diffuse large B-cell lymphoma, so-called Richter syndrome. Richter syndrome is often heralded by the development of a rapidly enlarging mass within a lymph node or the spleen. It is often associated with acquisition of new abnormalities involving TP53 or MyC and is an ominous event, with most patients surviving less than 1 year. Follicular lymphoma. Follicular lymphoma is the most common form of indolent NHL in the United States, trailing only diffuse large B-cell lymphoma in frequency among lymphomas. It affects 15,000 to 20,000 individuals per year. It usually presents in middle age and afflicts males and females equally. It is less common in Europe and rare in Asian populations. Pathogenesis. Follicular lymphoma is strongly associated with chromosomal translocations involving BCL2. Its hallmark is a translocation that juxtaposes the IGH locus on chromosome 14 and the BCL2 locus on chromosome 18. The T is seen in up to 90% of follicular lymphomas and leads to overexpression of BCL2. BCL2 antagonizes apoptosis and promotes the survival of follicular lymphoma cells. Notably, while normal germinal centers contain numerous B cells undergoing apoptosis, follicular lymphoma is characteristically devoid of apoptotic cells. Deep sequencing of follicular lymphoma genomes have identified mutations in the KMT2D gene in about 90% of cases as well. KMT2D encodes a histone methyltransferase, suggesting that epigenetic abnormalities such as changes in the patterns of histone marks have an important role in this neoplasm. Particularly early in the disease, follicular lymphoma cells growing in lymph nodes are found within a network of reactive follicular dendritic cells admixed with macrophages and T cells. Expression profiling studies have shown that differences in the genes expressed by these stromal cells are predictive of outcome, implying that the response of follicular lymphoma cells to therapy is influenced by the surrounding microenvironment. B. Figure 13.10 Follicular lymphoma. Nodular aggregates of lymphoma cells are present throughout lymph node. At high magnification, small lymphoid cells with condensed chromatin and irregular or cleaved nuclear outlines are mixed with a population of larger cells with nucleoli. Morphology. In most cases, a nodular and diffuse growth pattern is observed in involved lymph nodes. Two principal cell types are present in varying proportions. Small cells with irregular or cleaved nuclear contours and scant cytoplasm, referred to as centrocytes, and larger cells with open nuclear chromatin, several nucleoli, and modest amounts of cytoplasm, referred to as centroblasts. In most follicular lymphomas, centrocytes are in the majority. Peripheral blood involvement sufficient to produce lymphocytosis is seen in about 10% of cases. Bone marrow involvement occurs in 85% of cases and characteristically takes the form of paratrabecular lymphoid aggregates. The splenic, white pulp, and hepatic portal triads are also frequently involved. Figure 13.1. 1 follicular lymphoma. Prominent nodules represent white pulp follicles expanded by follicular lymphoma cells. Other indolent B-cell lymphomas can produce an identical pattern of involvement. A figure 13.12 BCL2 expression in reactive and neoplastic follicles. BCL2 protein was detected by using an immunohistochemical technique that produces a brown stain. In reactive follicles, BCL2 is present in mantle zone cells but not follicular center B cells, whereas follicular lymphoma cells show strong BCL2 staining. Immunophenotype. The neoplastic cells closely resemble normal germinal center B cells, expressing CD19, CD20, CD10, surface IG, and BCL6. Unlike CLL, SLL, and mantle cell lymphoma, CD5 is not expressed. BCL2 is expressed in more than 90% of cases, in distinction to normal follicular center B cells, which are BCL2 negative. Clinical features: follicular lymphoma tends to present with painless, generalized lymphadenopathy. Involvement of extranodal sites, such as the gastrointestinal tract, central nervous system, or testis, is relatively uncommon. Although incurable, it usually follows an indolent waxing and waning course. Survival is not improved by aggressive therapy, hence the usual approach is to palliate patients with low-dose chemotherapy or immunotherapy when they become symptomatic. Like CLL, it also is responsive to inhibitors of B-cell receptor signaling and inhibitors of BCL2. Histologic transformation occurs in 30% to 50% of follicular lymphomas, most commonly to DLBCL. These transformation events are frequently associated with aberrations that increase the expression of MyC, which you will recall drives Warburg metabolism and rapid cell growth. Follicular lymphomas show evidence of ongoing somatic hypermutation, which may promote transformation by causing point mutations or chromosomal aberrations. The median survival is less than 1 year after transformation. Diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is the most common form of NHL. Each year in the United States, there are about 25,000 new cases. There is a slight male predominance. The median patient age is about 60 years, but DLBCL also occurs in young adults and children. Pathogenesis genetic. Gene expression profiling and immunohistochemical studies indicate that DLBCL is molecularly heterogeneous. One frequent pathogenic event is dysregulation of BCL6, a DNA-binding zinc finger transcriptional repressor that is required for the formation of normal germinal centers. About 30% of DLBCLs contain various translocations that have in common a breakpoint in BCL6 at chromosome 3q. Acquired mutations in BCL6 promoter sequences that abrogate BCL6 autoregulation are seen even more frequently. It is hypothesized that both types of lesions are inadvertent byproducts of somatic hypermutation that result in overexpression of BCL6, which has several important consequences. BCL6 represses the expression of factors that normally serve to promote germinal center B-cell differentiation, growth arrest, and apoptosis, and each of these effects is believed to contribute to the development of DLBCL. Mutations similar to those found in BCL6 are also seen in multiple other oncogenes, including MyC, suggesting that somatic hypermutation in DLBCL cells is mistargeted to a wide variety of loci. Another 10% to 20% of tumors are associated with the T, which leads to the overexpression of the anti-apoptotic protein BCL2. Tumors with BCL2 rearrangements usually lack BCL6 rearrangements, suggesting that these rearrangements define two distinct molecular classes of DLBCL. Some tumors with BCL2 rearrangements may arise from unrecognized underlying follicular lymphomas, which frequently transform to DLBCL. Roughly 5% of DLBCLs are associated with translocations involving MyC. These tumors may have a distinctive biology. Finally, sequencing of DLBCL genomes has identified frequent mutations in genes encoding histone acetyltransferases such as P and CREP, proteins that regulate gene expression by modifying histones and altering chromatin structure. Morphology. The common features are a relatively large cell size and a diffuse pattern of growth. Other morphologic features show substantial variation. Most commonly, the tumor. Figure 13.1.3 diffuse large B-cell lymphoma. Tumor cells have large nuclei, open chromatin, and prominent nucleoli. Cells have a round or oval nucleus that appears vesicular due to margination of chromatin to the nuclear membrane, but large multilobated or irregular nuclei are prominent in some cases. Nucleoli may be 2 to 3 in number, and located adjacent to the nuclear membrane or single and centrally placed. The cytoplasm is usually moderately abundant and may be pale or basophilic. More anaplastic tumors may contain multinucleated cells with large inclusion-like nucleoli that resemble Reed-Sternberg cells. Immunophenotype. These mature B-cell tumors express CD19 and CD20 and show variable expression of germinal center B-cell markers such as CD10 and BCL6. Most have surface Ig. High-level expression of both MyC and BCL2 proteins is seen in some cases and may predict more aggressive behavior. Special subtypes. Several subtypes of DLBCL are sufficiently distinctive to merit brief discussion. Immunodeficiency-associated large B-cell lymphoma occurs in the setting of T-cell immunodeficiency. The neoplastic B-cells are usually infected with EBV, which plays a critical pathogenic role. Restoration of T-cell immunity may lead to regression of these proliferations. Primary effusion lymphoma presents as a malignant pleural or acidic effusion, mostly in patients with advanced HIV infection or in older adults. The tumor cells are often anaplastic in appearance and typically fail to express surface B or T cell markers, but have clonal IgH gene rearrangements. In all cases, the tumor cells are infected with HHV8, which appears to have a causal role. Clinical features: DLBCL typically presents as a rapidly enlarging mass at a nodal or extranodal site. It can arise virtually anywhere in the body. Waldeyer ring, the oropharyngeal lymphoid tissue that includes the tonsils and adenoids, is involved commonly. Primary or secondary involvement of the liver and spleen may take the form of large destructive masses. Figure 13.1. 4. Diffuse large B-cell lymphoma involving the spleen. The isolated large mass is typical. In contrast, indolent B-cell lymphomas usually produce multifocal expansion of white pulp. Extranodal sites include the gastrointestinal tract, skin, bone, brain, and other tissues. Bone marrow involvement is relatively uncommon and usually occurs late in the course. Rarely a leukemic picture emerges. DLBCLs are aggressive tumors that are rapidly fatal without treatment. With intensive combination chemotherapy, 60% to 80% of patients achieve a complete remission, and 40% to 50% are cured. Adjuvant therapy with anti-CD20 antibody improves both the initial response and the overall outcome. Individuals with limited disease fare better than those with widespread disease or bulky tumor masses. Expression profiling has identified several distinct molecular subtypes, including one resembling germinal center B cells and a second resembling activated post-germinal center B cells, each with differing clinical outcomes. DLBCLs with MyC translocations have a worse prognosis than those without and may be better treated with chemotherapy regimens that are now standard for Burkitt lymphoma. CAR T cells directed against the B-cell antigen CD19 are now available for the treatment of patients with relapsed refractory DLBCL. Burkitt lymphoma within the category of Burkitt lymphoma fall African Burkitt lymphoma, sporadic Burkitt lymphoma, and a subset of aggressive lymphomas occurring in individuals infected with HIV. Burkitt lymphomas occurring in these three settings are histologically identical but have distinct clinical, genotypic, and virologic characteristics. Pathogenesis. All forms of Burkitt lymphoma are associated with translocations of the MyC gene on chromosome 8 that lead to increased MyC protein levels. MyC is a master transcriptional regulator that increases the expression of genes that are required for aerobic glycolysis, the so-called Warburg effect. When nutrients such as glucose and glutamine are available, Warburg metabolism allows cells to biosynthesize all the building blocks, nucleotides, lipids, proteins that are needed for growth and cell division. In line with the importance of MyC in regulating proliferation, Burkitt lymphoma is among the fastest growing human tumors. The MyC translocation partner is usually the IgH locus, but may also be the Ig kappa or lambda light chain loci. The breakpoints in the IgH locus in sporadic Burkitt lymphoma are usually found in the class switch regions, whereas the breakpoints in endemic Burkitt lymphoma tend to lie within more 5VJ sequences. The basis for this subtle molecular distinction is not known, but both types of translocations can be induced in germinal center B cells by AID, a specialized DNA-modifying enzyme required for both Ig class switching and somatic hypermutation. The net effect of these translocations is similar. The MyC coding sequence is repositioned adjacent to strong Ig enhancer elements, which drive increased MyC expression. In addition, the translocated MyC allele often harbors point mutations that stabilize MyC protein and further increase its activity. Sequencing of the genomes of Burkitt lymphoma cells has revealed that most tumors have mutations that increase the activity of the transcription factor TCF3, also known as E2A, an important regulator of gene expression in germinal center B cells. It is believed that TCF3 drives the expression of a set of genes, including cyclin D, that collaborate with MyC to enable the very rapid growth that characterizes Burkitt lymphoma. Essentially, all endemic Burkitt lymphomas are latently infected with EBV, which also is present in about 25% of HIV-associated tumors and 15% to 20% of sporadic cases. The configuration of the EBV DNA is identical in all tumor cells within individual cases, indicating that infection precedes transformation. Although this places EBV at the scene of the crime, its precise role in the genesis of Burkitt lymphoma remains speculative. Morphology. Involved tissues are effaced by a diffuse infiltrate of intermediate-sized lymphoid cells 10 to 25 micrometers in diameter with round or oval nuclei, coarse chromatin, several nucleoli, and a moderate amount of cytoplasm. The tumor exhibits a high mitotic index and contains numerous apoptotic cells, the nuclear, remnants of which are phagocytosed by interspersed benign macrophages. These phagocytes have abundant clear cytoplasm, creating a characteristic starry sky pattern. When the bone marrow is involved, aspirates reveal tumor cells with slightly clumped nuclear chromatin, 2 to 5 distinct nucleoli, and royal blue cytoplasm containing clear cytoplasmic vacuoles. Immunophenotype. These are tumors of mature B cells that express surface IgM, CD19, CD20, CD10, and BCL6, a phenotype consistent with a germinal center B cell origin. Unlike most other tumors of germinal center origin, Burkitt lymphoma almost always fails to express the anti-apoptotic protein BCL2. Clinical features. Both endemic and sporadic Burkitt lymphomas are found mainly in children or young adults. Overall, Burkitt lymphoma accounts for about 30% of childhood NHLs in the United States. Most tumors manifest at extranodal sites. Endemic Burkitt lymphoma often presents as a mass involving the mandible and shows an unusual predilection for involvement of abdominal viscera, particularly the kidneys, ovaries, and adrenal glands. In contrast, sporadic Burkitt lymphoma most often appears as a mass involving the ileocecum and peritoneum. Involvement of the bone marrow and peripheral blood is uncommon, especially in endemic cases. Burkitt lymphoma is very aggressive but responds well to intensive chemotherapy. Most children and young adults can be cured. The outcome is more guarded in older adults. Mantle cell lymphoma. Mantle cell lymphoma is an uncommon lymphoid neoplasm that makes up about 2.5% of NHL in the United States and 7% to 9% of NHL in Europe. It usually presents in the 5th to 6th decades of life and shows a male predominance. As the name implies, the tumor cells closely resemble the normal mantle zone B cells that surround germinal centers. Pathogenesis. Virtually all mantle cell lymphomas have a translocation involving the IgH locus on chromosome 14 and the cyclin D1 locus on chromosome 11 that leads to overexpression of cyclin D1. The resulting upregulation of cyclin D1 promotes G1 to S phase progression during the cell cycle, as was described in Chapter 7. Morphology. B. Figure 13.15 Burkitt lymphoma. At low power, numerous pale tingible body macrophages are evident, producing a starry sky appearance. At high power, tumor cells have multiple small nucleoli and high mitotic index. The lack of significant variation in nuclear shape and size lends a monotonous appearance. At diagnosis, the majority of patients have generalized lymphadenopathy, and 20% to 40% have peripheral blood involvement. Frequent sites of extranodal involvement include the bone marrow, spleen, liver, and gut. Occasionally, mucosal involvement of the small bowel or colon produces polyp-like lesions. Of all forms of NHL, mantle cell lymphoma is most likely to spread in this fashion. Nodal tumor cells may surround reactive germinal centers too, produce a nodular appearance at low power, or diffusely efface the node. Typically, the proliferation consists of a homogeneous population of small lymphocytes with irregular A, B, Figure 13.1, 6 mantle cell lymphoma. At low power, neoplastic lymphoid cells surround a small atrophic germinal center, producing a mantle zone pattern of growth. High power view shows a homogeneous population of small lymphoid cells with somewhat irregular nuclear outlines, condensed chromatin, and scant cytoplasm. Large cells resembling prolymphocytes and centroblasts are absent, to occasionally deeply clefted nuclear contours. Large cells resembling centroblasts and proliferation centers are absent, distinguishing mantle cell lymphoma from follicular lymphoma and CLL/SLL respectively. In most cases, the nuclear chromatin is condensed. Nucleoli are inconspicuous, and the cytoplasm is scant. Occasionally, tumors composed of intermediate-sized cells with more open chromatin and a brisk mitotic rate are observed. Immunophenotyping is necessary to distinguish these blastoid variants from all. Immunophenotype. Mantle cell lymphomas express high levels of cyclin D1, CD19, and CD20, and moderately high levels of surface Ig. This tumor is usually CD5 and CD23, which help to distinguish it from CLL/SLL. The IDH genes lack somatic hypermutation, supporting an origin from a naive B cell. Clinical features: the most common presentation is painless lymphadenopathy. Symptoms related to involvement of the spleen and gut also are common. Mantle cell lymphoma is moderately aggressive and incurable. The median survival is 8 to 10 years. The blastoid variant, a proliferative expression profiling signature, and TP53 mutations are associated with shorter survivals. Marginal zone lymphomas. The category of marginal zone lymphomas encompasses a heterogeneous group of B-cell tumors that arise within lymph nodes, spleen, or extranodal tissues. The extranodal tumors were initially recognized at mucosal sites and are often referred to as mucosa-associated lymphoid tumors. In most cases, the tumor cells show evidence of somatic hypermutation and are considered to be of memory B-cell origin. Although all marginal zone lymphomas share certain features, those occurring at extranodal sites deserve special attention because of their unusual pathogenesis and 3 exceptional characteristics. They often arise within tissues involved by chronic inflammatory disorders of autoimmune or infectious etiology. Examples include the salivary gland in Sjogren disease, the thyroid gland in Hashimoto thyroiditis, and the stomach in Helicobacter gastritis. They remain localized for prolonged periods, spreading systemically only late in their course. They may regress if the inciting agent is eradicated. These characteristics suggest that extranodal marginal zone lymphomas arising in chronically inflamed tissues lie on a continuum between reactive lymphoid hyperplasia and full-blown lymphoma. The disease begins as a polyclonal immune reaction, with the acquisition of unknown initiating mutations. A B-cell clone emerges that still depends on antigen-stimulated T helper cells for signals that drive growth and survival. At this stage, withdrawal of the responsible antigen causes tumor involution. A clinically relevant example is found in gastric maltoma, in which antibiotic therapy directed against H. pylori often leads to tumor regression. With time, however, tumors may acquire additional mutations that render their growth and survival antigen-independent, such as or chromosomal translocations, which are relatively specific for extranodal marginal zone lymphomas. All of these translocations upregulate the expression and function of BCL10 or MALT1, protein components of a signaling complex that activates NF-kapab and promotes the growth and survival of B cells. With further clonal evolution, spread to distant sites and transformation to DLBCL may occur. This theme of polyclonal to monoclonal transition during lymphomagenesis is also applicable to the pathogenesis of EBV-induced lymphoma and is discussed more fully in Chapter 7. Hairy cell leukemia. This rare but distinctive B-cell neoplasm constitutes about 2% of all leukemias. It is predominantly a disease of middle-aged white males with a median age of 55 and a male-to-female ratio of 5:1. Pathogenesis. Hairy cell leukemia is associated in more than 90% of cases with activating point mutations in the serin threonine. 604, Chapter 13, Diseases of White Blood Cells, Lymph Nodes, Spleen, and Thymus. Kinase BRAF, which lies immediately downstream of RAS in the MAP signaling cascade. The specific mutation of valine to glutamate substitution at residue 600 is also found at high frequencies in many other neoplasms, including melanoma and Langerhans cell histiocytosis. Morphology. Hairy cell leukemia derives its picturesque name from the appearance of the leukemic cells, which have fine hair-like projections that are best recognized under the phase contrast microscope. On routine peripheral blood smears, hairy cells have round, oblong, or reniform nuclei and moderate amounts of pale blue cytoplasm with thread-like or bleb-like extensions. The number of circulating cells is highly variable. The marrow is involved by a diffuse interstitial infiltrative cells with oblong or reniform nuclei, condensed chromatin, and pale cytoplasm. Because these cells are enmeshed in an extracellular matrix composed of reticulin fibrils, they usually are inaspirable and are seen only in marrow biopsies. The splenic red pulp is usually heavily infiltrated, leading to obliteration of white pulp and a beefy red gross appearance. Hepatic portal triads are also involved frequently. Immunophenotype. Hairy cell leukemias typically express the pan-B cell markers CD19 and CD20 surface IG, and certain relatively distinctive markers such as CD11C, CD25, CD103, and annexin A1. Clinical features. Clinical manifestations result largely from infiltration of the bone marrow, liver, and spleen. Splenomegaly, often massive, is the most common and sometimes the only abnormal physical finding. Hepatomegaly is less common and not as marked. Lymphadenopathy is rare. Pancytopenia, resulting from marrow involvement and sequestration of cells in the enlarged spleen, is seen in more than half the cases. About 1/3 of those affected present with infections. There's an increased incidence of atypical mycobacterial infections, possibly related to monocytopenia of uncertain origin, which is commonly seen in this disease. Hairy cell leukemia follows an indolent course. For unclear reasons, it is exceptionally sensitive to gentle chemotherapeutic regimens, which produce long-lasting remissions. Tumors often relapse after 5 or more years, yet generally respond well when retreated with the same agents, a feature that is highly unusual among human cancers. BRAF inhibitors appear to produce excellent responses in tumors that have failed conventional chemotherapy. The overall prognosis is excellent. AB8, figure 13.17, hairy cell leukemia. Phase contrast microscopy shows tumor cells with fine hair-like cytoplasmic projections. In stained smears, these cells have round or folded nuclei and modest amounts of pale blue, a granular cytoplasm. Key concepts: common forms of lymphoid leukemia and lymphoma. Small lymphocytic lymphoma, chronic lymphocytic leukemia. Most common leukemia of adults. Tumor of mature B cells that usually manifests with bone marrow and lymph node involvement. Indolent course, commonly associated with immune abnormalities, including an increased susceptibility to infection and autoimmune disorders. Follicular lymphoma, most common indolent lymphoma of adults. Tumor cells recapitulate the growth pattern of normal germinal center B cells. Most cases are associated with a translocation that results in overexpression of BCL2. Diffuse large B-cell lymphoma. Most common lymphoma of adults. Heterogeneous group of mature B-cell tumors that shares a large cell morphology and aggressive clinical behavior. Rearrangements or mutations of BCL6 gene are recognized associations. 1/3 carrier translocation involving BBCL2 and may arise from follicular lymphomas. About 5% have translocations involving MyC. Burkitt lymphoma. Very aggressive tumor of mature B cells that usually arises at extranodal sites. Strongly associated with translocations involving the MyC proto-oncogene. Tumor cells often are latently infected by EBV. Mantle cell lymphoma. Tumor of naive B cells that pursues a moderately aggressive course. Highly associated with translocations involving the cyclin DI gene. Marginal zone lymphoma. Indolent tumors of antigen prime B cells that arise at sites of chronic immune stimulation. Often remain localized for long periods of time. Hairy cell leukemia. Morphologically distinct, very indolent tumor of mature B cells that involves spleen and marrow. Highly associated with mutations in the BRAF serine threonine kinase. Figure 13.1. 8 peripheral T-cell lymphoma unspecified. A spectrum of small, intermediate, and large lymphoid cells, many with irregular nuclear contours, is visible. Peripheral T and NK cell neoplasms. These categories include a heterogeneous group of neoplasms having phenotypes resembling mature T cells or NK cells. Peripheral T-cell tumors make up about 5% to 10% of NHLs. In the United States and Europe, while NK cell tumors are rare. By contrast, for unknown reasons, both T and NK cell tumors occur more frequently in the Far East. Only the most common diagnoses and those of particular pathogenetic interest will be discussed. Peripheral T-cell lymphoma, unspecified. Although the WHO classification includes a number of distinct peripheral T-cell neoplasms, many of these lymphomas are not easily categorized and are lumped into a wastebasket diagnosis: peripheral T-cell lymphoma, unspecified. As might be expected, no morphologic feature is pathognomonic, but certain findings are characteristic. These tumors efface lymph nodes diffusely and are typically composed of a pleomorphic mixture of variably sized malignant T cells. There is often a prominent infiltrate of reactive cells, such as eosinophils and macrophages, probably attracted by tumor-derived cytokines. Brisk neoangiogenesis may also be seen. By definition, all peripheral T-cell lymphomas are derived from mature T cells. They usually express CCD2, CCD3, CCD5, and either A's or Yo T cell receptors. Some also express CD4 or CD8. Such tumors are taken to be of helper or cytotoxic T-cell origin, respectively. However, many tumors have phenotypes that do not resemble any known normal T-cell. In difficult cases where the differential diagnosis lies between lymphoma and a florid reactive process, DNA analysis is used to confirm the presence of clonal T-cell receptor gene. Rearrangements. Most patients present with generalized lymphadenopathy, sometimes accompanied by eosinophilia pruritus, fever, and weight loss. Although cures of peripheral T-cell lymphoma have been reported, these tumors have a significantly worse prognosis than comparably aggressive mature B-cell neoplasms. Anaplastic large cell lymphoma. This uncommon entity is defined by the presence of rearrangements in the ALK gene on chromosome 2p. These rearrangements break the ALK locus and lead to the formation of chimeric genes encoding ALK fusion proteins, constitutively active tyrosine kinases that trigger the RAS and JAK-STAT signaling pathways. As the name implies, this tumor is typically composed of large anaplastic cells, some containing horseshoe-shaped nuclei and voluminous cytoplasm. The tumor cells often cluster about venules and infiltrate lymphoid sinuses, mimicking the appearance of metastatic carcinoma. ALK is not expressed in normal lymphocytes, thus the detection of ALK protein in tumor cells is a reliable indicator of an ALK gene rearrangement. T-cell lymphomas with ALK rearrangements tend to occur in children or young adults, frequently involve soft tissues, and carry a very good prognosis. The cure rate with chemotherapy is 75% to 80%. Inhibitors of ALK have been developed and have produced excellent responses in some tumors that have failed to respond to conventional chemotherapy. T-cell lymphomas that are morphologically similar but lack ALK rearrangements termed anaplastic large cell lymphoma tend to occur in older adults and have a substantially worse prognosis. Both ALK and ALK tumors usually express CD30, a member of the TNF receptor family. Notably, recombinant antibodies linked to toxins that recognize CD30 have significant anti-tumor activity against CD30 T-cell lymphomas and Hodgkin lymphoma, another CD30 tumor. Adult T-cell leukemia lymphoma. This neoplasm of CD4 T-cells is observed only in adults infected by HTLV-1. It occurs mainly in regions where HTLV-1 is endemic, namely southern Japan, West Africa, and the Caribbean basin. Common findings include skin lesions, generalized lymphadenopathy, hepatosplenomegaly, peripheral blood lymphocytosis, and hypercalcemia. 605. A. B. Figure 13.1. 9. Anaplastic large cell lymphoma. Several hallmark cells with horseshoe-like or embryoid nuclei and abundant cytoplasm lie near the center of the field. Immunohistochemical stain demonstrating the presence of ALK fusion protein, in addition to adult T-cell leukemia lymphoma. HTLV-1 infection also may give rise to a progressive demyelinating disease of the central nervous system and spinal cord. The appearance of the tumor cells varies, but cells with multilobated nuclei are frequently observed. The tumor cells always contain clonal HTLV-1 proviruses, suggesting a direct pathogenic role for the virus. However, while several proviral proteins have been implicated in the development of adult T-cell leukemia lymphoma, the tumor develops in only a small fraction of those who are infected, usually after a latent period of decades, and details of the transformation process remain poorly understood. Most patients present with rapidly progressive disease that is fatal within months to 1 year despite aggressive chemotherapy. Less commonly, the tumor involves only the skin and follows a much more indolent course like that of mycosis fungoides. Mycosis fungoides, Sézary syndrome. Mycosis fungoides and Sézary syndrome are different manifestations of a tumor of CD4 helper T cells that home to the skin. Clinically, the cutaneous lesions of mycosis fungoides typically progress through 3 somewhat distinct stages: an inflammatory premycotic phase, a plaque phase, and a tumor phase. Histologically, the epidermis and upper dermis are infiltrated by neoplastic T cells, which often have a cerebriform appearance due to marked infolding of the nuclear membrane. Late disease progression is characterized by extracutaneous spread, most commonly to lymph nodes and bone marrow. Sézary syndrome is a variant in which skin involvement is manifested as a generalized exfoliative erythroderma. In contrast to mycosis fungoides, the skin lesions rarely proceed to tumefaction, and there is an associated leukemia of Sézary cells with characteristic cerebriform nuclei. The tumor cells express the adhesion molecule, cutaneous leukocyte antigen, and the chemokine receptors CCR4 and CCR10, all of which contribute to the homing of normal CD4 T cells to the skin. Although cutaneous disease dominates the clinical picture, sensitive molecular analyses have shown that the tumor cells circulate through the blood, marrow, and lymph nodes even early in the course. Nevertheless, these are indolent tumors, with a median survival of roughly 10 years. Transformation to aggressive T-cell lymphoma occurs occasionally as a terminal event. Large granular lymphocytic leukemia T and NK cell variants of this rare neoplasm are recognized, both of which occur mainly in adults. Individuals with T-cell disease usually present with mild to moderate lymphocytosis and splenomegaly. Lymphadenopathy and hepatomegaly are usually absent. NK cell disease often presents in an even more subtle fashion, with little or no lymphocytosis or splenomegaly. Approximately 30% to 40% of large granular lymphocytic leukemias have acquired mutations in the transcription factor, STAT3, which functions downstream of cytokine receptors. These mutations occur in both T and NK cell forms of the disease and result in cytokine-independent activation of STAT3, which appears to have a major role in the pathogenesis of these proliferations. The tumor cells are large lymphocytes with abundant blue cytoplasm and a few coarse azurophilic granules, best seen in peripheral blood smears. The marrow usually contains a sparse interstitial lymphocytic infiltrate that is difficult to appreciate without immunohistochemical stains. Infiltrates also are usually present in the spleen and liver. T-cell variants express CD3 on their surfaces, whereas NK cell variants lack surface CD3 and express NK markers such as CD56. Despite the relative paucity of marrow infiltration, neutropenia and anemia dominate the clinical picture. Neutropenia may be accompanied by a striking decrease in late myeloid forms in the marrow. Rarely, pure red cell aplasia is seen. There is also an increased incidence of rheumatologic disorders. Some patients with Felty syndrome, a triad of rheumatoid arthritis, splenomegaly, and neutropenia, have this disorder as an underlying cause. The basis for these varied clinical abnormalities is unknown, but autoimmunity provoked in some way by the tumor seems likely. The course is variable, being largely dependent on the severity of the cytopenias and their responsiveness to low-dose chemotherapy or steroids. In general, tumors of T-cell origin pursue an indolent course, whereas NK cell tumors behave more aggressively. Extranodal NK, T-cell lymphoma. This neoplasm is rare in the United States, and Europe BU constitutes as many as 3% of NHLs in Asia. It most frequently presents as a destructive nasopharyngeal mass. Less common sites of presentation include the testis and the skin. The tumor cell infiltrate typically surrounds and invades small vessels, leading to extensive ischemic necrosis. In touch preparations, large azurophilic granules are seen in the cytoplasm of the tumor cells that resemble those found in normal NK cells. Extranodal NK T-cell lymphoma is highly associated with Epstein-Barr virus. Within individual patients, all of the tumor cells contain identical EBV episomes, indicating that the tumor originates from a single EVA-infected cell. How EBV gains entry is uncertain, since the tumor cells do not express CD21, the surface protein that serves as the B-cell EBV receptor. Most tumors are CD3 and lack T-cell receptor rearrangements and express NNK cell markers supporting an NNK cell origin. No consistent chromosome aberration has been described. Most extranodal NK T-cell lymphomas are highly aggressive neoplasms that respond well to radiation therapy but are resistant to chemotherapy. Thus, the prognosis is generally poor in patients with advanced disease. Recent work has shown, however, that like other virus-driven cancers, extranodal NK T-cell lymphoma responds well to immune checkpoint inhibitors, albeit with all of the attendant risks that are associated with these agents. Key concepts: peripheral T and NK cell neoplasms, peripheral NK T-cell lymphomas and leukemias, anaplastic large cell lymphoma, aggressive T-cell tumor, associated in a subset with translocations that lead to constitutive activation of the ALK tyrosine kinase, adult T-cell leukemia, lymphoma, aggressive tumor of CD4 T cells that is uniformly associated with HTLV1 infection. large granular lymphocytic leukemia, indolent tumor of cytotoxic T cells or NK cells that is associated with mutations in the transcription factor STAT3 and with autoimmune phenomena and cytopenias. Extranodal NK, T cell lymphoma, aggressive tumor, usually derived from NK cells that is strongly associated with EBV infection, plasma cell neoplasms and related disorders. These B-cell proliferations contain neoplastic plasma cells that virtually always secrete monoclonal Ig or Ig fragments, which serve as tumor markers and often have pathologic consequences. Collectively, the plasma cell neoplasms account for about 15% of deaths caused by lymphoid neoplasms. The most common and deadly of these neoplasms is multiple myeloma, of which there are about 15,000 new cases per year in the United States. A monoclonal Ig identified in the blood is referred to as an M component in reference to myeloma, because complete M components have molecular weights of 160,000 or higher. They are restricted to the plasma and extracellular fluid and excluded from the urine in the absence of glomerular damage. However, neoplastic plasma cells often synthesize excess light chains along with complete IGs. Occasionally, only light chains are produced, and rare tumors secrete only heavy chains. In most patients with plasma cell tumors, the level of free light chains is elevated and markedly skewed toward one light chain at the expense of the second. Because free light chains are small in size, they are also excreted in the urine, where they are referred to as Bence-Jones proteins. Terms used to describe the abnormal IGs associated with plasma cell neoplasms include monoclonal gammopathy and paraproteinemia. These abnormal proteins are associated with the following clinical pathologic entities. Multiple myeloma, the most important plasma cell neoplasm, usually presents as tumor masses scattered throughout the skeletal system. Solitary myeloma is an infrequent variant that presents as a single mass in bone or soft tissue. Smoldering myeloma refers to another uncommon variant defined by a lack of symptoms and a high plasma M component. Waldenstrom macroglobulinemia is a syndrome in which high levels of IgM lead to symptoms related to hyperviscosity of the blood. It occurs in older adults, most commonly in association with lymphoplasmacytic lymphoma. Heavy chain disease is a rare monoclonal gammopathy seen in association with a diverse group of disorders, including lymphoplasmacytic lymphoma and an unusual small bowel marginal zone lymphoma that occurs in malnourished populations. The common feature is the synthesis and secretion of free heavy chain fragments. Primary or immunocyte-associated amyloidosis results from a monoclonal proliferation of plasma cells secreting light chains that are deposited as amyloid. Some patients have overt multiple myeloma, but others have only a minor clonal population of plasma cells in the marrow. Monoclonal gammopathy of undetermined significance is applied to patients without signs or symptoms who have small to moderately large M components in their blood. MGU use is very common in older adults and may transform to multiple myeloma or other symptomatic plasma cell neoplasms. With this background, we now turn to some of these specific entities. Primary amyloidosis is discussed in Chapter 6. Multiple myeloma. Multiple myeloma is a plasma cell neoplasm commonly associated with lytic bone lesions, hypercalcemia, renal failure, and acquired immune abnormalities. Although bony disease dominates, it can spread late in its course to lymph nodes and extranodal sites. Multiple myeloma causes 1% of cancer deaths in Western countries. Its incidence is higher in men and people of African descent. It is chiefly a disease of older adults, with a peak age of incidence of 65 to 70 years. Pathogenesis. Multiple myeloma is genetically heterogeneous and is associated with frequent rearrangements involving the IGH locus on chromosome 14q and various proto-oncogenes. Included among the rearranged genes are the cell cycle, regulatory gene cyclin D1 on chromosome 11q, and cyclin D3 on chromosome 6p. Deletions of chromosome 17p that involve the TP53 tumor suppressor locus also occur and are associated with a poor outcome. Late stage, highly aggressive forms of the disease, such as plasma cell leukemia, are associated with rearrangements involving MyC. Deep sequencing of myeloma genomes has identified frequent mutations involving components of the NF-kappa pathway, which supports B-cell survival. The proliferation and survival of myeloma cells are dependent on several cytokines, most notably IL-6, which is an important growth factor for plasma cells. It is produced by the tumor cells themselves and by resident marrow stromal cells. High serum levels of IL-6 are seen in patients with active disease and are associated with a poor prognosis. Myeloma cell growth and survival are also augmented by direct physical interactions with bone marrow stromal cells, a phenomenon that is an area of intense research interest. Factors produced by neoplastic plasma cells mediate bone destruction, the major pathologic feature of multiple myeloma. One important factor appears to be myeloma-derived MIP1A-LPHA, a chemokine that augments osteoclast formation through several different mechanisms. Other factors released from tumor cells, such as modulators of the WNT pathway, are potent inhibitors of osteoblast function. The net effect is a marked increase in bone resorption, which leads to hypercalcemia and pathologic fractures. Figure 13.20. Multiple myeloma of the skull. The sharply punched out bone lesions are most obvious in the calvaria. Morphology. Multiple myeloma usually presents as destructive plasma cell tumors involving the axial skeleton. The bones most commonly affected in descending order of frequency are the vertebral column, ribs, skull, pelvis, femur, clavicle, and scapula. Lesions begin in the medullary cavity, erode cancellous bone, and progressively destroy the bony cortex, often leading to pathologic fractures. These are most common in the vertebral column, but may occur in any affected bone. The bone lesions appear radiographically as punched-out defects, usually 1 to 4 centimeters in diameter, and consist of soft, gelatinous, red tumor masses, less commonly widespread myelomatous bone. Disease produces diffuse demineralization rather than focal defects. Even away from overt tumor masses, the marrow contains an increased number of plasma cells, which usually constitute more than 30% of the cellularity. The plasma cells may infiltrate the interstitium in a subtle fashion or completely replace normal elements. Like their benign counterparts, malignant plasma cells have a perinuclear clearing due to a prominent Golgi apparatus. Figure 13.2. 1. Multiple myeloma. Normal marrow cells are largely replaced by plasma cells, including forms with multiple nuclei, prominent nucleoli, and cytoplasmic droplets containing immunoglobulin, and an eccentrically placed nucleus, relatively normal-appearing plasma cells, plasmablasts with vesicular nuclear chromatin, and a prominent single nucleolus or bizarre multinucleated cells may predominate. Other cytologic variants stem from the dysregulated synthesis and secretion of Ig, which often leads to intracellular accumulation of intact or partially degraded proteins. Such variants include flame cells with fiery red cytoplasm, moth cells with multiple grape-like cytoplasmic droplets, and cells containing a variety of other inclusions, including fibrils, crystalline rods, and globules. The globular inclusions are referred to as Russell bodies or Dutcher bodies. In advanced disease, plasma cell infiltrates may be present in the spleen, liver, kidneys, lungs, lymph nodes, and other soft tissues. Disorders of white cells 609. Commonly, high levels of M protein in the blood cause red cells to stick to one another in linear arrays in smears. A finding referred to as rouleau formation. Rouleau formation is characteristic but not specific, as it may be seen in other conditions in which Ig levels are elevated, such as lupus erythematosus and early HIV infection. Rarely, tumor cells flood the peripheral blood, giving rise to plasma cell leukemia. Bence-Jones proteins are excreted in the kidney and contribute to a form of renal disease called myeloma kidney. This important complication is discussed in detail in Chapter 20. Immunophenotype. Plasma cell tumors are positive for CD138, an adhesion molecule also known as syndecan-1 and often express CD56. A feature that can be helpful in identifying small populations of neoplastic cells. Clinical features. The clinical features of multiple myeloma stem from the effects of plasma cell growth in tissues, particularly the bones, the production of excessive Igs, which often have abnormal physicochemical properties, and the suppression of normal humoral immunity. Bone resorption often leads to pathologic fractures and chronic pain. The attendant hypercalcemia can give rise to neurologic manifestations, such as confusion, weakness, lethargy, constipation, and polyuria, and contributes to renal dysfunction. Decreased production of normal IgS sets the stage for recurrent bacterial infections. Cellular immunity is relatively unaffected. Of great significance is renal insufficiency, which trails only infections as a cause of death. The pathogenesis of renal failure, which occurs in up to 50% of patients, is multifactorial. However, the single most important factor seems to be Bence-Jones proteinuria, as the excreted light chains are toxic to renal tubular epithelial cells. Certain light chains are prone to cause amyloidosis of the AL type, which can exacerbate renal dysfunction and deposit in other tissues as well. In 99% of patients, laboratory analyses reveal increased levels of Igs in the blood and/or light chains in the urine. The monoclonal Igs are usually first detected as abnormal protein spikes in serum or urine electrophoresis, and then further characterized by immunofixation. Most myelomas are associated with more than 3 grams DL of serum Ig and/or more than 6 milligrams DL of urine Bence-Jones protein. The most common monoclonal Ig is IgG, followed by IgA. Myelomas expressing IgM, IgD, or IgE occur but are rare. Excessive production and aggregation of M proteins, usually of the IgA or IgG3 subtype, leads to symptoms related to hyperviscosity in about 7% of patients. Both free light chains and a serum M protein are observed together in 60% to 70% of patients. However, in about 20% of patients, only free light chains are present. And around 1% of myelomas are non-secretory, hence the absence of M proteins does not completely exclude the diagnosis. The clinical pathologic diagnosis of multiple myeloma relies on identification of clonal plasma cells in the marrow. Normal serum, SPG patient serum, SPG. Figure 13, M protein detection in multiple myeloma. Serum protein electrophoresis is used to screen for a monoclonal immunoglobulin. Polyclonal IgG in normal serum appears as a broad band. In contrast, serum from a patient with multiple myeloma contains a single sharp protein band in this region of the electropheretogram. The suspected monoclonal Ig is confirmed and characterized by immunofixation, in which proteins are trapped in the gel with antibodies specific for IgG, IgA, IgM, or kappa, or lambda light chain, and then visualized with a protein stain. Note, the sharp band in the patient serum is cross-linked by antisera specific for IgG heavy chain and kappa light chain, indicating the presence of an I-kappa M protein. Levels of polyclonal IgG, IgA, and lambda light chain are also decreased in the patient's serum relative to normal, a finding typical of multiple myeloma. And the presence of Crab criteria. It can be strongly suspected when the distinctive radiographic changes are present, but definitive diagnosis requires a bone marrow examination and tests assessing calcium levels, renal function, blood counts, and serum and urine Igs. The prognosis is variable. The median survival is 4 to 7 years, and cures have yet to be achieved. Patients with multiple bony lesions, if untreated, rarely survive for more than 6 to 12 months, whereas patients with smoldering myeloma may be asymptomatic for many years. Translocations involving cyclin D1 are associated with a good outcome, whereas deletions of 13q, deletions of 17p, and the T all portend a more aggressive course. While still incurable, outcomes have improved over the past decade with advances in therapy. Myeloma cells are sensitive to inhibitors of the proteasome, a cellular organelle that degrades unwanted and misfolded proteins. Because of the high levels of Ig synthesis, misfolding of Ig heavy and light chains may occur even in normal plasma cells. And this tendency may be exacerbated in myeloma cells in which heavy and light chain synthesis is unbalanced. If these misfolded proteins are not degraded in proteasomes, they trigger apoptosis. Proteasome inhibitors induce cell kappa death by exploiting this vulnerability, and also seem to retard bone resorption through effects on stromal cells. Thalidomide and related compounds such as lenalidomide also have activity against myeloma. Interestingly, this also appears to involve changes in protein degradation, as lenalidomide redirects and activates certain ubiquitin ligases, thereby targeting proteins for proteolysis that are required for myeloma growth. Bisphosphonates, drugs that inhibit bone resorption, reduce pathologic fractures, and limit hypercalcemia. HSC transplantation prolongs life, but has not been proven to be curative. Smoldering myeloma. This entity defines a middle ground between multiple myeloma and MGUs. Plasma cells make up 10% to 30% of the marrow cellularity, and the serum M protein level is greater than 3 GDL. But patients are asymptomatic. About 75% of patients progress to multiple myeloma over a 15-year period. Solitary osseous plasmacytoma, about 3% to 5% of plasma cell neoplasms, present as a solitary lesion of bone or soft tissue. The bone lesions tend to occur in the same locations as in multiple myeloma. Extraosseous lesions are often located in the lungs, oronasopharynx, or nasal sinuses. Modest elevations of M proteins in the blood or urine may be found in some patients. Solitary osseous plasmacytoma almost inevitably progresses to multiple myeloma, but this can take 10 to 20 years or longer. In contrast, extraosseous plasmacytomas, particularly those involving the upper respiratory tract, are frequently cured by local resection. Monoclonal gammopathy of undetermined significance. MGS is the most common plasma cell disorder, occurring in about 3% of persons older than 50 years of age, and in about 5% of individuals older than 70 years of age. By definition, patients are asymptomatic, and the serum M protein level is less than 3 grams DL. Approximately 1% of patients with MGUs develop a symptomatic plasma cell neoplasm, usually multiple myeloma, per year. The clonal plasma cells in MGUs contain many of the same chromosomal translocations and deletions that are found in full-blown multiple myeloma, indicating that MGUs is an early stage of myeloma development. As with smoldering myeloma, progression to multiple myeloma is unpredictable, hence periodic assessment of serum M component levels and Bence-Jones proteinuria is warranted. Lymphoplasmacytic lymphoma. Lymphoplasmacytic lymphoma is a B-cell neoplasm of older adults that usually presents in the 6th or 7th decade of life. Although superficially resembling CLL/SLL, it differs in that a substantial fraction of the tumor cells undergo terminal differentiation to plasma cells. Most commonly, the plasma cell component secretes monoclonal IgM, often in amounts sufficient to cause a hyperviscosity syndrome known as Waldenstrom macroglobulinemia. Unlike multiple myeloma, complications stemming from the secretion of free light chains are relatively rare, and bone destruction does not occur. Pathogenesis: virtually all cases of lymphoplasmacytic lymphoma are associated with acquired mutations in MyD88. MyDA encodes an adapter protein that participates in signaling events that activate NF-kappa, which may promote the growth and survival of the tumor cells. Morphology. Typically, the marrow contains an infiltrate of lymphocytes, plasma cells, and plasmacytoid lymphocytes in varying proportions, often accompanied by mast cell hyperplasia. Some tumors also contain a population of larger lymphoid cells with more vesicular nuclear chromatin and prominent nucleoli. Periodic acid shift positive inclusions containing Ig are frequently seen in the cytoplasm or the nucleus of some of the plasma cells. At diagnosis, the tumor has usually disseminated to the lymph nodes, spleen, and liver. Infiltration of the nerve roots, meninges, and more rarely, the brain can also occur with disease progression. Immunophenotype. The lymphoid component expresses B-cell markers such as CD20 and surface Ig, whereas the plasma cell component secretes the same Ig that is expressed on the surface of the lymphoid cells, usually IgM. Clinical features. The dominant presenting complaints are non-specific and include weakness, fatigue, and weight loss. Approximately half the patients have lymphadenopathy, hepatomegaly, and splenomegaly. Anemia caused by marrow infiltration is common. About 10% of patients have autoimmune hemolysis caused by cold agglutinins, IgM antibodies that bind to red cells at temperatures of less than 37 degrees Celsius. Patients with IgM-secreting tumors have additional signs and symptoms stemming from the physicochemical. Figure 13.23 Lymphoplasmacytic lymphoma. Bone marrow biopsy shows a characteristic mixture of small lymphoid cells exhibiting various degrees of plasma cell differentiation. In addition, a mast cell with purplish-red cytoplasmic granules is present at the left-hand side of the field. Properties of IgM. Because of its large size, at high concentrations, IgM greatly increases the viscosity of the blood, giving rise to a hyperviscosity syndrome characterized by the following. Visual impairment associated with venous congestion, reflected by striking tortuosity and distension of retinal veins. Retinal hemorrhages and exudates may also contribute to the visual problems. Neurologic problems such as headaches, dizziness, deafness, and stupor, all stemming from sluggish blood flow. Bleeding related to the formation of complexes between macroglobulins and clotting factors, as well as interference with platelet function. Cryoglobulinemia resulting from the precipitation of macroglobulins at low temperatures, producing symptoms such as Raynaud phenomenon and cold urticaria. Lymphoplasmacytic lymphoma is an indolent disorder. Because most IgM is intravascular, symptoms caused by the high IgM levels can be alleviated by plasmapheresis. Tumor growth can be controlled with low doses of chemotherapeutic drugs and immunotherapy with anti-CD20 antibody. Like other indolent B-cell tumors, lymphoplasmacytic lymphoma is highly responsive to BTK inhibitors, indicating a dependence of the tumor cells on the B-cell receptor signaling pathway. Transformation to large cell lymphoma occurs, but is uncommon. Median survival is about 8 years and may improve further with the recent addition of BTK inhibitors to the therapeutic armamentarium. Key concepts: plasma cell neoplasms, multiple myeloma, plasma cell tumor that manifests with multiple lytic bone lesions, associated with pathologic fractures and hypercalcemia. Neoplastic plasma cells suppress normal humoral immunity and secrete partial Igs that are nephrotoxic, associated with diverse translocations involving the IgH locus. Frequent dysregulation and overexpression of D-cyclins may be associated with amyloidosis, as may other neoplasms. Later, other plasma cell neoplasms, MGUs, common in older adults, progresses to myeloma at a rate of 1% per year. Smoldering myeloma, disseminated disease that pursues an unusually indolent course. Solitary osseous plasmacytoma, solitary bone lesion identical to disseminated myeloma, most progress to myeloma within 7 to 10 years. extramedullary plasmacytoma, solitary mass, usually in the upper aerodigestive tract, rarely progresses to systemic disease. Lymphoplasmacytic lymphoma, B-cell lymphoma that exhibits plasmacytic differentiation, clinical symptoms dominated by hyperviscosity related to high levels of tumor-derived IgM, highly associated with mutations in the MAD88 gene. Table 13.7 differences between Hodgkin and non-Hodgkin lymphomas. Hodgkin lymphoma, more often localized to a single axial group of nodes, cervical, mediastinal, para-aortic, orderly spread by contiguity, mesenteric nodes, and Waldeyer. Ring rarely involved. Extranodal presentation rare. Hodgkin lymphoma, non-Hodgkin lymphoma, more frequent involvement of multiple peripheral nodes, non-contiguous spread. Waldeyer ring and mesenteric nodes commonly involved. Extranodal presentation common. Hodgkin lymphoma encompasses a group of lymphoid neoplasms that differ from NHL in several respects. While NHLs frequently occur at extranodal sites and spread in an unpredictable fashion, Hodgkin lymphoma arises in a single node or chain of nodes and spreads first to anatomically contiguous lymphoid tissues. Morphologically, the distinctive feature of Hodgkin lymphoma is the presence of neoplastic giant cells called Reed-Sternberg cells. These cells release factors that induce the accumulation of reactive lymphocytes, macrophages, and granulocytes, which typically make up greater than 90% of the tumor cellularity. Molecular studies have shown that the neoplastic Reed-Sternberg cells are derived from germinal center or post-germinal center B cells. Hodgkin lymphoma accounts for 0.7% of all new cancers in the United States. There are about 8,000 cases each year. The average age at diagnosis is 32 years. It is one of the most common cancers of young adults and adolescents, but also occurs in the aged. It was the first human cancer to be successfully treated with radiation therapy and chemotherapy, and is curable in most cases. Classification. The WHO classification recognizes 5 subtypes of Hodgkin lymphoma. 1. Nodular sclerosis. 2. Mixed cellularity. 3. Lymphocyte, rich 4 lymphocyte depletion, 5 nodular lymphocyte predominance. In the first 4 subtypes, nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depletion, the Reed-Sternberg cells have a similar distinctive immunophenotype. These subtypes are often lumped together as classic forms of Hodgkin lymphoma. In the remaining subtype, lymphocyte predominance, the Reed-Sternberg cells have a B-cell immunophenotype that differs from that of the classic types. Pathogenesis. The origin of the neoplastic Reed-Sternberg cells of classic Hodgkin lymphoma was solved through elegant molecular studies of single isolated Reed-Sternberg cells. These revealed clonal IgH gene rearrangements and the telltale signs of somatic hypermutation, establishing that Reed-Sternberg cells originate from a germinal center or post-germinal center B cell. Despite their B cell origin, the Reed-Sternberg cells 611 of classic Hodgkin lymphoma fail to express most B cell specific genes, including the Ig genes. The cause of this wholesale reprogramming of gene expression has yet to be explained and presumably results from widespread epigenetic changes of uncertain etiology. Activation of the transcription factor NFB is a common event in classic Hodgkin lymphoma and turns on genes that are believed to promote the growth and survival of Reed-Sternberg cells. This can occur by several mechanisms. EBV tumor cells express latent membrane protein 1, a protein encoded by the EBV genome that transmits signals that upregulate NF-kappa. Activation of NF-kappa may occur in EBV tumors as a result of acquired loss of function mutations in ECAPAB or TNF-alpha-induced protein 3, both of which are negative regulators of NF-kappa. It is hypothesized that activation of NF-kappa rescues crippled germinal center B cells that cannot express Ig from apoptosis, setting the stage for the acquisition of other unknown mutations that collaborate to produce Reed-Sternberg cells. Little is known about the basis for the morphology of Reed-Sternberg cells and variants, but it is intriguing that EBV-infected B cells resembling Reed-Sternberg cells may be found in the lymph nodes of individuals with infectious mononucleosis, strongly suggesting that EBV-encoded proteins play a part in the remarkable metamorphosis of B cells into Reed-Sternberg cells. Reed-Sternberg cells are aneuploid and possess diverse clonal chromosomal aberrations. Copy number gains in the REL proto-oncogene on chromosome 2p are particularly common and may also contribute to increases in NF-kappa activity. Also frequent are copy number gains in genes encoding PDL1 and PDL2, located together on chromosome 9p, which you will recall are immune checkpoint proteins that inhibit anti-tumor T-cell responses. The florid accumulation of reactive cells in tissues involved by classic Hodgkin lymphoma occurs in response to a wide variety of cytokines, chemokines, and other factors that are secreted by Reed-Sternberg cells. Once attracted, the reactive cells produce factors that support the growth and survival of the tumor cells and further modify the reactive cell response. For example, eosinophils and T cells express ligands that activate the CD30 and CD40 receptors found on Reed-Sternberg cells, producing signals that upregulate NF-kappa. Although Reed-Sternberg cells induce a host response, it is ineffective because of factors produced by the Reed-Sternberg cells. Most notably among these factors are PDL1 and PDL2, which antagonize cytotoxic T-cell responses. Other examples of crosstalk between Reed-Sternberg cells and surrounding reactive cells are provided in Figure 13. 28. Morphology. Identification of Reed-Sternberg cells and their variants is essential for the diagnosis. Diagnostic Reed-Sternberg cells are large cells with multiple nuclei or a single nucleus with multiple nuclear lobes, each with a large inclusion like nucleolus about the size of a small lymphocyte. The cytoplasm is abundant. Several Reed-Sternberg cell variants are also recognized. Mononuclear variants contain a single nucleus with a large inclusion like nucleolus. Lacunar cells have more delicate, folded, or multilobate nuclei and abundant pale cytoplasm that is often disrupted during the cutting of sections, leaving the nucleus sitting in an empty space. In classic forms of Hodgkin lymphoma, Reed-Sternberg cells undergo a peculiar form of cell death in which the cells shrink and become pycnotic, a process described as mummification. Lymphohistiocytic variants with polypoid nuclei, inconspicuous nucleoli, and moderately abundant cytoplasm are characteristic of the lymphocyte predominant subtype. Hodgkin lymphoma must be distinguished from other conditions in which cells resembling Reed-Sternberg cells may be seen, such as infectious mononucleosis, solid tissue cancers, and large cell NHLs. The diagnosis of Hodgkin lymphoma depends on the identification of Reed-Sternberg cells in a background of non-neoplastic inflammatory cells. Reed-Sternberg cells also have a characteristic immunohistochemical profile, a feature that is used to confirm the morphologic impression. With this as background, we turn to the subclasses of Hodgkin lymphoma, pointing out some of the salient morphologic and immunophenotypic features of each. The clinical manifestations common to all are presented later. Nodular sclerosis type. This is the most common form of Hodgkin lymphoma, constituting 65% to 70% of cases. It is characterized by the presence of lacunar variant Reed-Sternberg cells and the deposition of collagen in bands that divide involved lymph nodes into circumscribed nodules. The fibrosis may be scant or abundant. The Reed-Sternberg cells are found in a polymorphous background of T cells, eosinophils, plasma cells, and macrophages. Diagnostic Reed-Sternberg cells are often uncommon. The Reed-Sternberg cells in this and other classic Hodgkin lymphoma subtypes have a characteristic immunophenotype. They are positive for PAX5, CD15, and CD30 and negative for other B-cell markers, T-cell markers, and CD45. As in other forms of Hodgkin lymphoma, involvement of the spleen, liver, bone marrow, and other organs and tissues may appear in due course in the form of irregular tumor nodules resembling those seen in lymph nodes. This subtype is uncommonly associated with EBV. The nodular sclerosis type occurs with equal frequency in males and females. It has a propensity to involve the lower cervical, supraclavicular, and mediastinal lymph nodes of adolescents or young adults. The prognosis is excellent. Mixed cellularity type. This form of Hodgkin lymphoma constitutes about 20% to 25% of cases. Involved lymph nodes are diffusely effaced by a heterogeneous cellular infiltrate, which includes T cells, eosinophils, plasma cells, and benign macrophages admixed with Reed-Sternberg cells. Diagnostic Reed-Sternberg cells and mononuclear variants are usually plentiful. The Reed-Sternberg cells are infected with EBV in about 70% of cases. The immunophenotype is identical to that observed in the nodular sclerosis type. Mixed cellularity Hodgkin lymphoma is more common in males. Compared with the lymphocyte predominance and nodular sclerosis subtypes, it is more likely to be associated with older age, systemic symptoms such as night sweats and weight loss, and advanced tumor stage. Nonetheless, the overall prognosis is very good. A B, C, D figure. 13.2. 4 Reed-Sternberg cells and variants. Diagnostic Reed-Sternberg cell with 2 nuclear lobes, large inclusion-like nucleoli, and abundant cytoplasm surrounded by lymphocytes, macrophages, and an eosinophil. Reed-Sternberg cell, mononuclear variant. Reed-Sternberg cell, lacunar variant. This variant has a folded or multilobated nucleus and lies within an open space, which is an artifact created by disruption of the cytoplasm during tissue sectioning. Reed-Sternberg cell lymphohistiocytic variant. Several such variants with multiply in folded nuclear membranes, small nucleoli, fine chromatin, and abundant pale cytoplasm are present. Table 13.8 Subtypes of Hodgkin lymphoma, subtype morphology and immunophenotype nodular sclerosis, frequent lacunar cells and occasional diagnostic RS cells, background infiltrate composed of T lymphocytes, eosinophils, macrophages, and plasma cells, fibrous bands dividing cellular areas into nodules, RS cells, CD15, CD30, usually EBV. Mixed cellularity, frequent mononuclear and diagnostic RS cells, background infiltrate, rich in T lymphocytes, eosinophils, macrophages, plasma cells, RS cells, CD15, CD30, 70% EBV. Lymphocyte rich, frequent mononuclear and diagnostic RS cells, background infiltrate. Rich in T lymphocytes, RS cells, CD15, CD30, 40% EBV. Reticular variant, frequent diagnostic RS cells and variants, and a paucity of background reactive cells, RS cells, CD15, CD30, most EBV. Frequent LAN variants in a background of follicular dendritic cells and reactive B cells, RS cells, CD20, CD15, CD30, EB. HIV, human immunodeficiency virus, LNH, lymphohistiocytic, RS, Reed-Sternberg, lymphocyte depletion, nodular lymphocyte predominant. Typical clinical features, most common subtype, usually stage 1 or TIU disease, frequent mediastinal involvement, equal occurrence in males and females, most patients young adults. More than 50% present as stage 3 or IV disease. Occurrence greater in males than females. Biphasic incidence. Peaking in young adults and again in adults older than 55. Uncommon. Occurrence greater in males than females. Tends to be seen in older adults. Uncommon, more common in older men, HIV-infected individuals, and people in low-income countries. Often presents with advanced disease. Uncommon young males with cervical or axillary lymphadenopathy mediastinal. Figure 13.25 Hodgkin lymphoma, nodular sclerosis type. Low power view shows well-defined bands of pink acellular collagen that subdivide the tumor into nodules. Figure 13.27 Hodgkin lymphoma, lymphocyte predominance type. Numerous mature-looking lymphocytes surround scattered, large, pale-staining lymphohistiocytic variants. Figure 13.26 Hodgkin lymphoma, mixed cellularity type. A diagnostic binucleate Reed-Sternberg cell is surrounded by reactive cells including eosinophils, lymphocytes, and macrophages. Lymphocyte-rich type. This is an uncommon form of classic Hodgkin lymphoma in which reactive lymphocytes make up the vast majority of the cellular infiltrate. In most cases, involved lymph nodes are diffusely effaced, but vague nodularity due to the presence of residual B-cell follicles is sometimes seen. This entity is distinguished from the lymphocyte predominance type by the presence of frequent mononuclear variants and diagnostic Reed-Sternberg cells with a classic immunophenotypic profile. It is associated with EBV in about 40% of cases and has a very good to excellent prognosis. Lymphocyte depletion type. This is the least common form of Hodgkin lymphoma, amounting to less than 5% of cases. It is characterized by a paucity of lymphocytes and a relative abundance of Reed-Sternberg cells or their pleomorphic variants. The immunophenotype of the Reed-Sternberg cells is identical to that seen in other classic types of Hodgkin lymphoma. Immunophenotyping is essential, since most tumors suspected of being lymphocyte depletion, Hodgkin lymphomas actually prove to be large cell NHLs. The Reed-Sternberg cells are infected with EBV in over 90% of cases. Lymphocyte depletion. Hodgkin lymphoma occurs predominantly in older adults, in HIV-positive individuals of any age, and in individuals living in lower-income countries. Advanced stage and systemic symptoms are frequent, and the overall outcome is less favorable than in the other subtypes. Nodular lymphocyte predominance type. This uncommon non-classic variant of Hodgkin lymphoma accounts for about 5% of cases. Involved nodes are effaced by nodules of small lymphocytes admixed with variable numbers of macrophages. Classic Reed-Sternberg cells are usually difficult to find. Instead, this tumor contains so-called L and H variants with multi-lobed nuclei resembling popcorn kernels. Eosinophils and plasma cells are usually scant or absent, in contrast to the Reed-Sternberg cells found in classic forms of Hodgkin lymphoma, LAND. H variants express B-cell markers typical of germinal center B cells, such as CD20 and BCL6, and are usually negative for CD15 and CD30. The nodular pattern of growth is due to the presence of expanded B-cell follicles populated by LAND variants, numerous reactive B cells, and follicular dendritic cells. The IGH genes of the LAND variants show evidence of ongoing somatic hypermutation, further marking these cells as transformed germinal center B cells. In 3% to 5% of cases, this type transforms into a tumor resembling diffuse large B-cell lymphoma. EBV is rarely associated with this subtype. A majority of patients are males, usually younger than 35 years of age, presenting with cervical or axillary lymphadenopathy. Mediastinal and bone marrow involvement is rare. In some series, this form of Hodgkin lymphoma is more likely to recur than the classic subtypes, but the prognosis is excellent. Clinical features Hodgkin lymphoma most commonly presents as painless lymphadenopathy. Patients with the nodular sclerosis or lymphocyte predominance types tend to have stage 1 or 2 disease and are usually free of systemic manifestations. Patients with disseminated disease or the mixed cellularity or lymphocyte depletion subtypes are monocyte, macrophage infiltration activation, MCSF, IL-13 or IL-13, c-MET, TH, IL-10, CTL, PDL1, PD receptor, Galectin-1, various chemokines. IL-5, CD30, CD30L, enhanced TREG response. Tissue eosinophilia, HGF, various chemokines. CD40, CD40L, TNF-alpha, BFGF, eotaxin, dendritic cells, TH, enhanced TH response, eotaxin, figure 13.28, proposed signals mediating crosstalk between Reed-Sternberg cells and surrounding normal cells in classic forms of Hodgkin. Lymphoma, BFGF. Basic fibroblast growth factor, CD30L, CD30 ligand, CTL, CD8 cytotoxic T cell, HGF, hepatocyte growth factor, IL, interleukin MCSF, monocyte colony stimulating factor, CYP4 T helper cell subsets, TNF alpha, tumor necrosis factor alpha, TREG, regulatory T cell. More likely to have constitutional symptoms such as fever, night sweats, and weight loss. Cutaneous immune unresponsiveness resulting from depressed cell-mediated immunity is seen in most cases of classic Hodgkin lymphoma and is attributable to the expression of factors such as IL-10 by Reed-Sternberg cells that suppress TH immune responses. This is but one of many examples of crosstalk between Reed-Sternberg cells, various stromal cells, and immune cells. The spread of Hodgkin lymphoma is remarkably stereotypic. Nodal disease first, then splenic disease, hepatic disease, and finally involvement of the marrow and other tissues. Staging involves physical examination, radiologic imaging of the abdomen, pelvis, and chest, and biopsy of the bone marrow. With current treatment protocols, tumor stage rather than histologic type is the most important prognostic variable. The cure rate of patients with stages 1 and TIA is close to 90%. Even with advanced disease, disease-free survival at 5 years is 60% to 70%. Low-stage localized Hodgkin lymphoma can be cured with involved field radiotherapy, and indeed cure of such patients was one of the early success stories in oncology. However, it was subsequently recognized that long-term survivors treated with radiotherapy had a much higher incidence of certain other malignancies, including lung cancer, melanoma, and breast cancer. Patients treated with early chemotherapy regimens containing alkylating agents also had a high incidence of secondary tumors, particularly AML. These sobering results spurred the development of current treatment regimens, which minimize the use of radiotherapy and employ less genotoxic chemotherapeutic. Table 13.9, clinical staging of Hodgkin and non-Hodgkin lymphomas. Stage distribution of disease. I involvement of a single lymph node region or a single extralymphatic organ or site. 2. Involvement of 2 or more lymph node regions on the same side of the diaphragm alone or localized involvement of an extralymphatic organ or site. 2. Involvement of lymph node regions on both sides of the diaphragm without or with localized involvement of an extralymphatic organ or site. IV diffuse involvement of 1 or more extralymphatic organs or sites with or without lymphatic involvement. All stages are further divided on the basis of the absence or presence of the following symptoms: unexplained fever, drenching night sweats, and or unexplained weight loss of greater than 10% of normal body weight. Data from Carbone PT et al. Symposium, Staging in Hodgkin's Disease, Cancer Res 31, 1707, 1971. Agents. As a result, the incidence of secondary tumors appears to have been reduced markedly without any loss of therapeutic efficacy. For patients with classic Hodgkin lymphoma who fail conventional therapy, immune checkpoint inhibitors that block PD-1, the receptor for PD-L1 and PD-L2, have proven to be highly effective. These agents prevent the CD8 cytotoxic T-cell exhaustion that is caused by PD-L1 and PD-L2 expressed on Reed-Sternberg cells and lead to sustained responses in almost 90% of cases. Mantle cell lymphoma, cyclin D1 translocations, Burkitt lymphoma. Many examples: MyC translocations, follicular lymphoma, BCL2 translocations, sustained proliferative signaling, evading growth suppressors, Hodgkin lymphoma, PD-1 ligand gene amplification, deregulating cellular, energetics, avoiding immune destruction, resisting cell death. 8. Enabling replicative immortality. Tumor, promoting inflammation, genomic instability, XX, inducing angiogenesis, activating invasion and metastasis. Germinal center B-cell lymphomas. Class switching, somatic hypermutation. All mutations in lineage, specific transcription factors, marginal zone lymphoma, antigen dependency, relatively unimportant due to intrinsic ability of lymphoid cells to invade and circulate. Figure 13.2. 9 cancer hallmarks exemplified by particular lymphoid neoplasms. See text for details. Indeed, classic Hodgkin lymphoma appears to be the human cancer that is most responsive to immune checkpoint inhibitor therapy. Key concepts. Hodgkin lymphoma. Unusual tumor consisting mostly of reactive lymphocytes, macrophages, eosinophils, plasma cells, and stromal cells mixed, with rare tumor giant cells called Reed-Sternberg cells, and variants. 2 broad types, classic and nodular, lymphocyte predominant, which are distinguished based on morphologic and immunophenotypic grounds. Reed-Sternberg cells of classic types express multiple cytokines, chemokines, and ligands that influence the host response, and the responding host cells in turn make factors that support the growth of the tumor cells. Classic forms are frequently associated with acquired mutations that activate the transcription factor NFB and with EBV. Infection. Lymphocyte predominance type expresses B-cell markers and is not associated with EBV. Classic Hodgkin lymphoma is highly responsive to immune checkpoint inhibitors which antagonize the activity of PD-L and PDL2 expressed on the surface of Reed-Sternberg cells. Pathogenic lessons from lymphoid neoplasms. Before ending our review of lymphoid neoplasms, it is worthwhile pausing to summarize the manner in which common driver mutations in specific entities produce changes in cellular behavior that exemplify particular hallmarks of cancer. Some of the best characterized pathogenic mechanisms are summarized in Figure 13.29, including dysregulation of MyC in Burkitt lymphoma, dysregulation of BCL2 in follicular lymphoma, PD-1 ligand gene amplification in Hodgkin lymphoma, events leading to loss of cell cycle control, cyclin D1, rearrangements in mantle cell lymphoma, and loss of the CDKN2A gene in acute lymphoblastic leukemia, mutations in various transcription factors, particularly in all that block differentiation and enhance leukemia stem cell self-renewal, and chronic immune stimulation in marginal zone lymphoma. Such alterations not only highlight important pathogenic principles, but are increasingly the targets of effective therapies such as antibodies that block PD-1 and drugs that antagonize BCL2. By contrast, because lymphoid cells normally circulate throughout the body, there is relatively little selective pressure in lymphoid malignancies for aberrations that increase angiogenesis.